To all of you. Good morning to people in the US. Good afternoon to people in the UK. And good night to people in the Southeast, Singapore and Malaysia. Because it's a pan-international ophthalmic webinar on the occasion of the World Diabetes Day. Friends, Rajan Eye Care is entering the Silver Jubilee year this year. 25 years of commitment to excellence in eye care. And that has been our motto. We have the trust, technology, and total eye care of more than 1 million patients. Friends, I want to inform all the people here, excellent faculty, the galaxy of faculty from various subspecialties, I would say, cardiologists, nephrologists, general diabetologists, professors, former vice chancellor, everybody is here. Just to inform you that RIOS, Rajan Eye Ophthalmic Education Series, is an educational initiative which has been undertaken by Rajan Eye Care about 4 years back. And every last Friday of every month, we used to have physical meetings at our hospital in our conference hall, and mainly touching on the ophthalmic subjects, which benefited the postgraduates, the residents, and also the practicing ophthalmologists in and around Chennai. Today, we thought that we'll do something different, and that is the Diabetes and You webinar. This Diabetes and You webinar on the occasion of the World Diabetes Day is to create awareness among everybody. So this webinar, the participants are not only general doctors, ophthalmologists, but also the non-medical people who need to know, and many of them being diabetics, and diabetes, as you know, the prevalence and incidence is increasing day after day. It's like a time bomb. And to discuss this, we thought we'll have a very exhaustive webinar on this particular issue. And giving the keynote address will be Dr. Vijay Vishwanathan, followed by particular problems like diabetes and eye, diabetes and heart, and diabetes and kidney by the various speakers. The speakers will be introduced by my co-moderator, Dr. Ravi Shankar, and I'll be introducing the head of the panel and the other panelists for this webinar. We have the greatest pleasure and honor of having Professor D. Shantaram as the head of the panel. He doesn't require any introduction. He is a person who is, in my opinion, the gold standard as far as diabetology in this part of the world is concerned. Dr. Shantaram is from the illustrious Madras Medical College. He was 1 year senior to me in MMC. More importantly, he is the senior consultant diabetologist for the Apollo Hospitals, Maine, and Apollo Sugar Clinic. He has held very important positions. The former vice chancellor of the prestigious Tamil Nadu Dr. MGR Medical University, and former director, Institute of Diabetology, Stanley Medical College, member Ethics Committee, Medical Council of India, Chairman Selection Committee, JIPMER, member Academic Committee, Jawaharlal Nehru Institute of Postgraduate Medical, and that is JIPMER. Many awards like Best Teacher Award for the Tamil Nadu Government, MGR Medical University, Tamil Nadu Medical Council, Lifetime Achievement Awards from MV Hospital, that is Vijay's and Dr. Vishwanathan's hospital, and many other awards and accolades. And to talk about him, it will take one full day. Professor Shantaram, I think it's a great pleasure and to welcome you for this webinar, sir. Your inputs in this particular webinar on all the topics which you are going to discuss today is going to become very, very valuable for all of us. I have also the pleasure of introducing our esteemed panel. And all the panelists are from Rajan Eye Care. We have Dr. Sujata Mohan, Executive Medical Director of Rajan Eye Care Hospital. Except for retina and oculoplasty, she does all the other surgeries as far as eyes are concerned. She is an expert in cataract, cornea, LASIK, refractive, phakic IOLs, glaucoma, and name it. She is really a fantastic surgeon. She has finished her FRCS Glasgow, and she's done a postgraduate from Shankar Nethralaya and trained in the UK in cornea and refractive surgery. Dr. Sujata Mohan has got several publications, and her YouTube channels are one of the most popular as far as ophthalmologists in this part of the world is concerned. We also have Dr. Manoj Khatri. Dr. Manoj Khatri is actually a D&B student from Rajan Eye Care, but subsequently did his fellowship from Shankar Nethralaya Vitreoretinal Fellowship and also from Eli Prasad Eye Institute. He is also an FRCS Glasgow. Manoj Khatri heads the department of the retina and vitreous in Rajan Eye Care and IDocs Hospital. He is a fantastic VR surgeon and has got very good concepts as far as diabetic retinopathy is concerned. Thank you very much, Manoj, for accepting to be here, and welcome Dr. Manoj Khatri and Dr. Sujata. And of course, we have Dr. Ramya Vivek. Ramya is, I would say, an authority in the retina, more so in a condition which is becoming very, very, increasing in magnitude day after day. That is in newborn babies and premature babies. That is the retinopathy of prematurity, ROP. Or we used to call it retrolental fibroplasia a long time back. Now it's called ROP. Ramya is an expert in this, in screening, in doing lasers. And we have a very, very busy project called the ROTA-ROP, which is a part of the Rotary Retinopathy of Prematurity project, which Ramya is taking care along with Dr. Shupriya. And it's always a pleasure to have Ramya in this panel to give her inputs as well. With these few words, we go on to the first speaker, and I request Dr. Ravi Shankar to introduce the first speaker, Dr. Vijay Vishwanathan.
Very good evening, esteemed panelists and the wonderful speakers of this very important meeting, which definitely will go a long way for the doctors, the physicians, the diabetologists, and everyone to understand about the disease, and at the same time for the general public to know how they can come to the physician as early as possible to get their problems treated. Thank you so much, Dr. Mohan Rajan, Dr. Sujata Mohan, for making this happen, this wonderful meeting. Thank you. May I have the pleasure to introduce this gentleman who completed about 3 decades, around 29 years in the field of diabetology, a PhD in diabetic nephropathy, has published 50 research papers in this particular field, has been awarded Vivian Fonseca from the American Diabetes Association for the work in diabetes mellitus and tuberculosis. His brainchild, diabetic foot care specialty in India, has gone a long way, where he's put his heart and soul in working for diabetic foot in this part of the world. The Podiatry Center at Chennai, which is his brainchild, is running for the past 25 years. The head and chief diabetologist, MV Hospital for Diabetes, Chennai, and continuing the legacy of Professor M. Viswanathan, the legendary in diabetology in this country, the father of diabetology. May I have the pleasure to introduce to the audience this great gentleman, Dr. Vijay Viswanathan.
Thank you, Dr. Ravi Shankar. Yeah, thank you, Dr. Ravi Shankar. My talk is about 10 to 12 minutes. I have 2 pleasant duties to do before I start. One is to thank Dr. Mohan Rajan and Sujata for asking me to talk. The second is on behalf of the public of Chennai to express my appreciation and feeling of what the public feel about Mohan Rajan's clinic for the wonderful work they're doing to society and all the social service they're doing. So I have 2 present pleasant duties to do before I start. And the third duty is to thank Professor Shantaram, who's our senior diabetologist and the ex-Vice Chancellor of Tamil Nadu, the great Tamil Nadu Dr. MGR Medical University. And what I'm going to do in the next 10 to 12 minutes is to give you a bird's eye view on what's happening in India as far as the diabetes care is concerned. So I hope you can see my slides. And,
yes, Vijay. Go ahead.
So where are we in 2020 in diabetes care in India is the title. And in the first 1 minute, I should talk about what has happened during the COVID crisis on diabetes. So what has happened is that COVID has really had a negative impact on diabetes, by which I mean that people could not have a proper food intake, they could not do a proper exercise program, energy expenditure came down, their lifestyle changed, and they could not access medical care. They could not go for the treatment to diabetic retinopathy, or if they had a food problem, they could not go to a podiatrist. So there was a real threat to diabetes control. Way back in May 2020, this year, we did this survey among patients by sending them a survey through a monkey survey, trying to find out how they were coping with diabetes during the COVID. Majority of them said they are coping well with diabetes during the COVID crisis. This was published in Diabetes and Metabolic Syndrome somewhere in June this year. But the important point I would like to say was people, though they could not go out into a laboratory for testing their blood sugar, many of them were not testing their blood sugar levels at home, which is the best thing to do by having a glucose monitor. Only 28% of the participants were checking their blood sugar. And even among the patients who were taking insulin, 65% were not regularly checking their blood sugar, which is not a good trend for a country like India. We have a lot of glucose monitors for 1,000 rupees, 1,500 rupees. The cost of the script is 20 rupees. So I think one of the important highlighting points from this study, which was an online pilot survey, was that people in India should start testing their blood sugar. So in such pandemics, they will know where their blood sugar controls are. Going out of the COVID, way back in 2010, much before all these pandemics were there, we published this data looking at the cost of diabetes care in India. And at that time, there were no costly drugs, there was no COVID crisis. And in 2010, 10 years ago, in this population-based study, we found that the cost of diabetes care was about $31.9 billion US. Now, the important point in this study, which I'm not highlighting as a slide, was the fact that the patient and the primary caregiver, so supposing the husband is a patient and he gets admitted with a foot infection, the wife, who's also a working woman, also accompanies the husband. There is a loss of median income and loss of man days for both the patient and the primary caregiver. So it's not just this money, but people lose their revenue, their earning potential when some complication of diabetes like retinopathy or foot complications set in. This was an editorial Lancet asked me to write 2 years ago, where I emphasized the need for improved diabetes care in India, because as you see, people are not monitoring their blood sugars properly, and there is a need for preventing diabetes complications like retinopathy or amputations or kidney failure in India. The important point to remember is wherever Indians stay, whether it is South Africa or London, or even in the Fiji Islands, Paul Zimmet had shown in the Fiji Islands, the Indians staying there have got more diabetes than the local population. So if you take Fiji Islands, the Indians staying there have more diabetes than the Fiji population, Fiji locals. Not only that, the important point to remember is most of the Indians get their diabetes by the age of 50. You can see that nearly 55% of Indians develop their diabetes before they have reached the age of 50, which is not the case with the Western population. Western population gets diabetes after the age of 50, majority of them. But in India, people get diabetes at a very young age. So this was from the Chennai Urban Rural Study, or the CURE study. Now, the important point to remember is that diabetes that does not start when it is diagnosed. Say, supposing somebody goes and examines his blood sugar and he's told he's a diabetic. This is the point. But you can see that diabetes starts at least 10 years before somebody is diagnosed with diabetes. And you can see the postprandial blood sugar rises, then the fasting goes up. The microvascular complications like diabetic retinopathy or microalbuminuria or neuropathy sets in at least 5 years before the actual development of diabetes. So I'm going to talk to you for 30 seconds on what is pre-diabetes. So pre-diabetes is, some people don't believe in the word pre-diabetes. They say it's a glycemic continuum. But I think it's very important to understand that there is a condition called pre-diabetes, which is a chronic metabolic condition which goes on for 4 or 5 years, where the blood sugars are higher than normal, but not high enough to be diagnosed as diabetes. I'm not showing you the slide, but about 11 years ago, we had shown that about 19.3% of pre-diabetics have diabetic neuropathy. So complications start even before the diabetes starts. The prevalence of pre-diabetes is currently in India is around 25 million. And by 2045, another 20 years later, it will reach about 40 million people. So these are all people who are likely to get heart disease, as Manoj is going to tell you, and also at risk of developing future diabetes. Therefore, I think in India, what we need to do is to aim for what is called primary prevention, where we try to postpone the diabetes of people who have pre-diabetes from getting diabetes. If they already become diabetic, to prevent complications like retinopathy and so on by what is called secondary prevention. And if supposing somebody has got retinopathy, to prevent the sight-threatening diabetic retinopathy by taking proper treatment. And if they've got microalbuminuria or an EGFR of, say, 60, to prevent it from going to an EGFR of 20, where you will need dialysis. Now, a lot of studies have shown that if you reduce your HbA1c from 9 to 7, 7.9 to 7, 7.5 to 6.4, you can prevent microvascular complications, mortality, and so on. But the situation in India, these are all Indian studies, which have shown that majority of the Indians have an HbA1c of 8.5. These are all treated patients. They're not treatment naive patients. Treated patients have a HbA1c of 8.5, 8.9. And studies have shown that if you bring it to 7, 6.5, whatever, you can prevent complications. But in India, most of the treated patients have a value of 8.5, 8.9, and so on. Why is it so difficult to manage diabetes in India? Because we are very high carb takers. We have very high postprandial levels. Our patients are simply not prepared to start insulin at the right time. They want to go on and on and on with drugs, with tablets, and they simply refuse insulin. There have been a lot of, I'll take another 5 minutes, and there have been a lot of advancements in the management of diabetes from 1970s. You can see this curve. And today we have a class of drugs which are called the SGLT2 inhibitors, which are creating a sensation all over the world. In between, we had a lot of agents which have come. Biconides like metformin are still standing the test of time, but we have fantastic agents like the SGLT2 inhibitors. Now, the treatment goals for people who are old, elderly, above the age of 60 or 65 has changed. So if you have somebody who's 70 years old, you need not always aim for 7%. If you have somebody who's elderly, who has mild to moderate cognitive impairment or multiple coexisting chronic illnesses, even 8 is okay. Or if you have somebody who's got severe cognitive impairment, even 8.5 is okay. So the target which we mentioned in the earlier slides is not for people who are elderly, who have a lot of comorbidities. So this is one point which I thought I should say, because this is a new entity, because every time we used to say 7%. But if you have elderly people who have these comorbidities, you need not get 7%, even 8 or 8.5 is enough. I was talking to you about the SGLT2 inhibitors. So this is the latest American Diabetes Association guidelines, which says that if you have atherosclerotic cardiovascular disease or heart failure, or impending heart failure or CKD, metformin is good, but you should be using a drug called SGLT2 inhibitors, which act like this. They work in the kidney and they increase the glucosuria, and they have got protective effect on the kidneys, on the blood vessels, and on the heart. And maybe Manoj will talk more about it in his talk. There have been data from Bernard Zillman's group in the United States which has shown that if you have people with nephropathy and a blood pressure which is high, if you use drugs like the SGLT2 inhibitors, like the empagliflozin, you can actually reduce the primary outcomes like CV death, total mortality, and so on. So it's very important that we know that such agents exist and should be used as an add-on to metformin when somebody has got, as I showed you in the previous slide, somebody has got an impending heart failure or established atherosclerotic cardiovascular disease. As far as insulins are concerned, we have a couple of insulins which are really game changers today. We have what is called the DegAsp or IDeg from Novo Nordisk, which is, you don't have to mix the insulins already. It's a co-formulation. You don't have to mix the two, the vial or the cartridge as you take it. It has got two parts, the ASP and the deglutec, the long-acting component. So when you inject it, what happens is the rapid-acting insulin immediately gets absorbed into the capillaries. The deglutec, the long-acting one, takes a longer time and provides the long-term control. So it might be possible to control somebody's blood sugar with 1 dose in the morning, or with 1 dose in the morning, 1 dose in the evening, because many times patients are forced to take insulin before breakfast, before lunch, before dinner, and after dinner, basal bolus. So this can probably be a substitute for people who are taking insulin 4 times a day. This new insulin in the Indian market called Glargine U300 has really revolutionized. Its earlier U100 also played a very important role, but the U300 gives you an absolutely peakless insulin. As you can see, the green color, the U300 gives you. So there is very little risk of hypoglycemia. We talked about the diabetes in the elderly. So you can see that it's an absolutely peakless insulin. So it can be taken at any time of the day. It can be taken in the evening, in the morning, and it works for 24 hours or even beyond that. And it has no peak, so there is no fear of hypoglycemia. You can combine it with SGLT2 inhibitors, metformin, or other drugs which the patient is taking. The U300 came about a year or a year and a half ago. The U100 was there much earlier. So the U300 has got many advantages, like the deglutec or isodec. It's got a more gradual and slow release from the depot. The U300 has got a flexible dosing, as I told you, and you can take it. You need not take it at the same time like the U100. You can take it at 8 p.m. one day, 9 p.m. one day, and so on. And there is less glycemic variability. There is another insulin, the fast-acting insulin called Glulisine, which has got a long window period. So when you inject elderly people, or when you inject insulin into a very small child who's 5 years old, the only fear is the child after the insulin injection may not take the food on time. Therefore, this Glulisine, which is called Apidra, which is still a little faster than the recently introduced Fiasp, has got a window period of 35 minutes. So you can take it either 15 minutes before the meal or 20 minutes after the meal. So you have a window period. So you can take the insulin even after you take the food. So this is one new development in India. And the last 2-3 minutes, let me talk to you about a new concept which has come to India, which is called the glycemic variability. Earlier, we used to say that just HbA1c, fasting, and PP blood sugar, what we called as a triad. But today we have something called a hexad, which talks about an entity called glycemic variability. And HbA1c alone may not be sufficient because there is a concept called glycemic variability, which refers to the fluctuation in blood sugar within the same day or from one day to the other. And there is a new concept which is now coming into vogue called time and range, TIR. For the person with diabetes or with retinopathy should have a TIR of at least 70%. That means 70% of the time, which is about 17 hours, they should be within the control. So TIR should be about 70%. The glycemic variability is such that it should be the number of hours you are going below the target, and the amount of time you're going above the target should be less. And therefore, the TIR is a concept which can reduce retinopathy risk by 64%, nephropathy risk by about 40%, and neuropathy risk by about 25%. And the only way to improve to get a person to 70% is by reducing the hyperglycemia and reducing the hypoglycemia. For 70% of the 24-hour period, the person remains in control. I would like to conclude. I've come to the last bit of my talk where there are two videos. I hope it works. I'll have to probably go off the highlighter and I don't know how to switch on this. Let me see.
Vijay?
Yeah.
I think you have to go to the, it's not linked to the PowerPoint, probably go to the file and click on the video.
I'm just trying to come off the pointer. So if I come out of the pointer, it'll be okay. No.
The video is not linked to the PowerPoint?
Let me see. Yeah, I think it's come, yeah.
Yeah, can you just share your screen again?
Yeah, 1 minute. Can you see this screen? No.
No. Please share your screen.
I'll have to get my video. One minute, then just share screen after that. So.
Right. Yeah. We're able to see your screen now.
So this is a insulin pump. This is looking different. This is an insulin delivery system. So here I can show you the other video. This is also available in India.
Which company is making this?
Medtronic.
What is the cost of the pump, Vijay?
So this is the most expensive pump, about 3 lakhs.
Hmm.
You don't have to do your blood test. I'll show the other one also, and then I'll.
Yeah.
Oh, I'm sorry.
What is this?
So this is a glycemic variability testing. So it's not, the video is not getting. Yeah. So
It's working, sir. Now it's working, sir.
Yeah.
Yeah, it's working. Okay.
Does it have?
What exactly you do in this?
So here you can measure your sugar levels 100 times in a day without poking.
100 times in a day. Okay.
You take it in the 1 o'clock in the night, 2 o'clock in the night, but without blood, totally bloodless.
Okay.
It has to be changed every day, is it, Dr. Vijay?
So no, so this is. Oh, I don't know. I'll switch off my video.
It is subcutaneous.
I have to stop sharing 1 minute.
You're already on screen.
No. Yes, stop sharing. Yeah.
Finished my talk. So there are two technologies which you saw here. One is the sensor which you fix here, and it can show you the sugar levels 100 times in a day for 14 days without a drop of blood. So it can show you the glycemic variability, the sugar levels at different times of the day, the night, day, one day to the other, and so on. And this is available in India from Freestyle Libera, it's called. The second is an insulin pump where, in addition to bloodless monitoring, you can also deliver your insulin. This is very inexpensive. It's only about 2,000 rupees for 14 days. But the pump is quite costly. It's about 3 lakhs. But you're totally independent of the insulin injections and pricking device. It's only for people who are not controlled with multiple doses of insulin. So thank you, Dr. Mohan, for this invitation. And I hope I was able to give some idea of what's happening in India.
Yeah, that was a brilliant talk, Vijay. I think you have opened up new vistas as far as the management of diabetes mellitus is concerned, and also the recent concepts in the management of DM, newer drugs as well, newer modalities of treatment. Now, let's open the panel now. Since you have got another function to go, let's take some questions, sir. We have to start from the guru, the head of the panel, Professor Shantaram, sir. I would like your comments on this Vijay's talk and also your inputs, sir.
Yes, unmute. Yes, to unmute, Mohan.
Yeah, please unmute, sir. Can you just unmute, sir? Yes.
Dr. Vijay, I just have one small question before Dr. Shantaraman sets his mic. Just want to know, is there any difference between obese diabetes and thin diabetics?
Yeah, so I think sir has got a problem with this.
No, let me call him up.
So the thing is, the obese diabetics have more insulin resistance. The thinner ones have more insulin secretory defect. If you measure the insulin levels or the C-peptide assay, you will find it quite high in the obese people and very low in the lower people, in the less BMI people. The less BMI people are more insulinopenic. Therefore, they will require insulin earlier. Whereas the obese people have to just lose weight. They do well with bariatric surgery or metabolic surgery. So there is a big difference between the obese category and the thin category. Sir Shantaram sir, we would be happy to.
Sir, are you online, sir?
Can you hear me?
Yes, sir.
Yeah.
I wanted your comments on Vijay's talk, sir, and
Yes.
your inputs also.
Yes. Thank you for the excellent lecture on the role of diabetes and the current scenario of type 2 diabetes in India, highlighting various challenges faced in the Indian diabetic scenario, like one, early age of onset of diabetes, two, the lack of awareness resulting in late diagnosis and sometimes diagnosis with the complications of diabetes, higher prevalence of pre-diabetics with a high conversion rate, and then accessibility to the healthcare is also uneven in India, with especially the epidemic occurring in the rural settings now. There is a narrowing urban-rural divide, which is increasing the diabetes burden in India. And he has nicely highlighted how the treatment has transformed from mere glucose control to prevention of diabetes complications with the newer drugs like SGLT2 and GLP-1 agonists. So now we have drugs which will not only control the sugar, but also prevent some of the diabetes complications or reverse the diabetes complications. And also is highlighted on the advances in the insulin therapy. Hypoglycemia was one of the limiting factors in initiating insulin with respect to the clinician, especially the fear of hypoglycemia made them delay the initiation of insulin, which had resulted in poorer control and more complications. So the newer insulins like Glargine, DegAsp, all these things with the peakless activity can control the sugar without exposing the patient to the risk of hypoglycemia. Not only that, he has nicely addressed how the metrics have changed from mere glucose control, A1C, to the control of variability, which also contributes to the diabetes complications. And the newer drugs, especially the SGLT2, the DPP4, and the newer insulins, they reduce the glucose variability. But most important one should remember is the glucose variability can be minimized only by the consistency in the lifestyle modification, be it exercise, be it timing of the food, the quality of the food, or quantity of the food, or the duration of the sleep, or the mental state. If these things fluctuate huge, then the variability will be much more. So general public should understand the essence of diabetes treatment is lifestyle modification, and drugs are there to help you to reduce the sugar to keep it at a threshold, which is less than for the development of the complications. The drugs, they do not stop the progression, they do not prevent the complications. It is only your lifestyle which can slow down the progression, and good control of sugar can prevent the complications. If you have a good lifestyle, you will stay on minimum drugs for a longer period of time. If your lifestyle is not good, the drug burden will keep on increasing at shorter intervals.
Thank you very much, sir. I think all messages are very golden messages as far as the diabetes is concerned. Vijay, I just wanted to ask, as an ophthalmologist, we always, when we monitor diabetic retinopathy in a patient, we take the HbA1c as a baseline. Okay, you told us that HbA1c is not as good as you think. That we'll have to go in for a different thing like a TIR or something like that. But I just want to know what exactly it is. As far as the retinopathy is concerned, because as an ophthalmologist, I'm interested in that. And also, Professor Shantaram was mentioning about, sir, I just want to know, is there, you said, I think Vijay also mentioned, you also said that when they diagnose diabetes, it means that they've had the diabetes for almost 5 years or something like that. I'm not sure what exactly is the duration. Because normally we say that the retinopathy occurs after 5 years after the onset of the diabetes mellitus. So how do you know exactly what time they started the diabetes started in them, number one, and how do you advise the physicians and diabetologists to make sure that they go to an ophthalmologist the very next day they diagnose as diabetes mellitus? Because we usually see many patients coming very late, after 5 or 10 years after the onset of the diabetes mellitus, because they have not had any problems with the vision, but they come with the stage 4 diabetic retinopathy when they come to us. So these are 2 issues, sir.
Just to answer before sir answers.
Yes.
So I think there is a lot of studies which have shown that type 2 diabetes starts much earlier and you have missed the bus, and there is a long phase of latent, undetected, undiagnosed period of hyperglycemia, which is quite mild, not major. So during which time neuropathy and retinopathy sets in. So if you have a strong family history of diabetes, if you're above the age of 40, if you have had a macrosomic baby earlier, we should encourage frequent testing of HbA1c and glucose tolerance test for people, like you do a master health checkup. So you should detect diabetes much before actually it is actually detected when you go to remove your teeth or something like that. Number one. Number two, about glycemic variability, I think HbA1c is still the tool which is universally accepted. But of late, the glycemic variability has started coming in, and this concept of TIR, but we still need a lot of data, a lot of research to come in. But there are some people who have HbA1c of 7, but they go into repeated hypoglycemia. So that's where the TIR concept is very useful. Like in the middle of the night, if they're taking this 2-geo insulin, 30 units at 8:30, at 2 o'clock in the night, they can go into hypoglycemia. And early morning, the sugars go up, called somogy. So that you cannot ask the patient to get up in the night and check every hour while he's sleeping. Therefore, the concept of glycemic variability and the patch which you saw might help to avoid a drop in blood sugar, especially in elderly people in the night. Sir, your comment, sir?
Yes, sir.
Dr. Rajan's question was the 5 years of diagnosis. We have got 2 types of diabetes. One is type 1 and type 2. The type 1, the recommendation is 5 years of the onset. Type 2, it is not that. At diagnosis, you have to screen for retinopathy, because as Vijay said, there is a latent, it is an asymptomatic disorder. People detect diabetes when they go for some other test. Normally, so in Indian scenario, as Vijay has pointed out, we are more prone. At the age of 30, from the age of 30, everybody should go for diabetes screening every year. Since studies have shown if pre-diabetes is detected, the lifestyle intervention can reduce the risk of developing diabetes. That's the thing. So type 2 diabetes, right at the onset, they have to go for eye screening. But type 1 diabetes is 5 years.
5 years. Okay, sir. So the age of 30 or 40, because Vijay said 40 and you said 30, but I would prefer 25, I would say, because we see a lot of patients who are really at the age of 25 because family history of diabetes, they're coming with diabetic retinopathy straight away. And 25 years, very young diabetics, because of the changes in the lifestyle. Professor Shantaram was rightly telling the changes in the lifestyle. I think it's a lot of stressful job. And now COVID pandemic has added to the whole stress now. People have lost jobs. Economy is at a very low ebb. All these problems are there. So whether to fix it at 25, 30 or 40.
I agree with you that since type 2 diabetes in the young is increasing now, which earlier we had more of type 1 diabetes in the young age. Now we see a lot of type 2 diabetes in the young age because of the increasing prevalence of obesity now. Though Indians develop diabetes at much lower BMI than the Caucasians, now our BMI is also increasing. So at least in patients who are obese with strong family history of diabetes. We can move the age still further down also to 25. It's only early screening to detect. But if they don't have any family history or they're not obese with no other comorbidities, probably 30 or 40 years, which I said, ours is a resource poor country, so it's easy to talk about screening.
Yes,
But typically, we have to look at that also.
yeah. Any comments from Sujata, Manoj Khatri, and Ramya on this? Then we go on to Dr. Manoj and Ram Prabhakar also. Do they have any comments?
I just have one comment. Normally, that when we were doing our undergraduation, the first drug of choice used to be metformin. And now Vijay says that there is a newer drug which is now so how does it differ, Vijay? Am I asking too much or?
No. It's a very controversial subject. So the European Society of Cardiology says if you have a atherosclerotic cardiovascular disease, you don't have to start with metformin. You can start with SGLT.
SGLT.
SGLT2 inhibitor.
Okay.
SGLT.
So SGLT2 inhibitors, empagliflozin, dapagliflozin. It's a little controversial subject, but in India, we still follow the route of metformin first and SGLT2 as an add-on.
Okay.
Dr. Manoj will definitely give SGLT2 as a first choice after a heart attack or after putting a stent.
Yeah. There are drugs which come in combination, right? There are drugs which have metformin along with the same drug. Combinations are available.
Yeah, fixed dose combinations with SGLT2, with gliptins like sitagliptin, everything is available.
Yeah.
Thank you, Dr. Mohan. I think we give a chance to other speakers to start speaking.
It's good. It's interesting.
Manoj Khatri, yeah. Quickly, one or two comments. Ramya.
Excellent talk, sir. As usual, Vijay sir, you always have a master stroke talks. That's what I say. And quite surprised to see here too many slides today. Normally, you will have only one or two slides in your presentation. We have seen
Dr. Mohan said talk for 15 minutes. Otherwise, I had prepared for 8 minutes.
I know. You said 5 minutes.
Yes.
You said 5. I said 15 minutes you have to talk.
Yes, couple of add-on things. What we have seen in our practice in last, especially 1 decade, is diabetic retinopathy, non-diabetics as well. And I'm sure you have seen those patients and diagnose them as having diabetes. And you rightly said the preset of all this disease happens 5 to 10 years earlier on the time from where we diagnose as having diabetes. So we see these patients quite often, and more so in post-COVID now. Patients say, I'm not a diabetic, I just have a vision loss, and they're coming for a checkup with a retinopathy. That is one worrying factor. And also there is an increased trend in worsening of sight-threatening diabetic retinopathy, especially in last 1 year. So that is also one of the major concerns what we are seeing. And, it's becoming a huge burden. In spite of giving them repeated sessions of treatment, they don't respond that well. So that is also, as a diabetologist, nephrologist, all of us have to, retinologist also, all of us has to, correlate and see what link where we are missing and try to give the maximum benefit to these patients. So these are a couple of add-on points from my side.
Yeah.
Thank you, Manoj.
Quick one or two remarks from Ramya, and then we go on to the next talk.
Sir, I enjoyed the talk very much. And I got answers for a lot of questions through your talk, because we have a lot of young diabetics who are becoming blind in front of our eyes, whom HbA1c control is very difficult. And most of them are early 40s and late 30s who present with us with proliferative diabetic retinopathy. Though we insist on HbA1c control and glycemic variability and all that, few studies have shown that early onset type 2 diabetics have some genetic mutations in beta cells. So I have seen your setup, and I have personally worked for about 2 months in your setup in the ophthalmology department, and I know how comprehensive your hospital is in patient care. So would you do something different for these early onset type 2 diabetics? Is there something that you do for these patients, especially because since they present with a lot of complications in early life?
Maybe, Ramya, you're talking about a condition called LADA, latent autoimmune diabetes of adults, where they are insulinopenic, as Dr. Sujata said. They're very lean and they go into ketosis very fast. They have very poor beta cell function, very high blood sugar. They are only 25, 30 years old. So you should do a C-peptide assay, GAD antibody test, and you see positivity in them. And these are probably the hard nut to crack. Because the typical type 2s they have a very slow progression of kidney disease and retinopathy. Whereas these LADAs and type 1s have a very fast progression.
Okay, sir.
Thank you, Mohan. I think you should go on to the next
I
speaker.
think you have to go for the other thing. Thank you very much, Vijay. And
Thank you, sir.
wish you a very
Wonderful talk.
happy and safe Diwali as well.
Thank you.
I will talk about I'm going to ask Professor Shantaram later about the insulin resistance. We always have a lot of doubts because many patients come and ask me about this, and I do not know have any clue about that. So we'll talk about it during the panel discussion, sir. We'll go on to the next speaker.
You're muted, Ravi Shankar. You're muted. Unmute. You're muted, yeah.
Thank you. Thank you once again. And it's my privilege to introduce the next speaker, a keen academician, presented at multiple international and national podiums as an invited speaker, co-editor of the textbook of vitreoretinal diseases and surgery, has vast experience in the field of vitreoretina and has served in leading ophthalmic institutions in the country. It's a proud moment for us to have you here. And currently heading the retinopathy of prematurity department at Rajan Eye Care Hospital and a senior consultant of vitreoretina services, Rajan Eye Care Hospital. May I have the pleasure to introduce Dr. Supriya Dabir Gautam to the audience. Welcome, Dr. Supriya.
Supriya, all yours.
Thank you, sir. I was literally expecting drum rolls the way you mentioned. Just give me a minute. Yeah. I'd like to begin with the onset of thanking Dr. Rajan for giving me the opportunity to be a part of this esteemed panel. The talk. So can you see my screen?
No, we are not able to see.
Just a minute. Is it visible now?
Yes.
Okay, great.
Very much.
Yeah, thank you so much. So I'm going to be talking about diabetes in the eye and especially the retina, which is diabetic retinopathy. So Dr. Vishwanathan just told us how diabetes is here to stay. It's an epidemic, not though we've forgotten it in this pandemic age right now, but it's here to stay. And the working age population is the one who are affected right now. And diabetic retinopathy is the leading cause of blindness in working age adults. The prevalence of diabetic retinopathy in India is about 20 to 25%. And what we call sight-threatening diabetic retinopathy is what we call as proliferative diabetic retinopathy or diabetic macular edema. These are the stages where there is a definite vision drop and intervention is essential. So I'm going to come to the different stages. Just a brief anatomy of the eye. So what you have in the front is your cornea. The light enters through this, goes through the lens, enters a clear cavity called the vitreous and falls on the retina. And the retina is made of 10 layers, which are a complex structure of cells and blood vessels. So you have a neurovascular network out here. And the light which goes through the vitreous cavity, through the eye, goes through the optic nerve to the brain. And your final perception of vision is at the level of the cortex here. So you need an entire, not just an intact eye, but an intact optic nerve and its path in the brain itself to have good vision. So how does diabetes affect the eye? So hyperglycemia causes various structural and functional changes. So you have deficient tear films in these patients. There could be changes in refraction. So we usually have a lot of patients who come with sudden hyperglycemia and now they can't see. So it's basically the lens of the eye, which because of hyperglycemia and the osmosis, it gets fluid vacuoles inside it and there's a drop in the vision. So this is something that is, can be reversible. So we usually tell patients to not worry, get their sugars under control and come back for refraction after the sugars are controlled because the number could vary. Then they have early onset of cataracts. And what I'm going to concentrate on today is diabetic retinopathy. So retina is this inner layer of the eye, more like the film of a camera on which the image is taken. So here what happens is if you can look at this blood vessel, they could be outpouching. A lot of structural changes due to inflammation, hyperglycemia. This outpouching is called a microaneurysm. When this ruptures, you get leakage. And because of this abnormal blood vascular blockage, then you start getting abnormal blood vessels. And this is called neovascularization. Neo means new blood vessels which are formed. And this forms the main pathogenesis of diabetic retinopathy. Yeah. And what you get changes in the retina is, this is the optic nerve, and this is the center of the retina called the macula. These are hemorrhages, that is those blood spots here. These are leakage of cholesterol within the retina. These are small minor infarcts or exoplasmic stasis in the retina, and small microaneurysms are outpouching, and you can see how dilated and tortuous these vessels are. So these are the various changes that you get. This is how a healthy retina looks, and this is how an eye with diabetic retinopathy looks. So it has been classified as non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So non-proliferative could begin as mild, where you just see small outpouchings or small hemorrhages. Moderate, where the changes are much more. You see some amount of cholesterol deposition, some infarcts, cotton wool spots. Extensive in all the quadrants of the eye when it becomes severe non-proliferative diabetic retinopathy. And now comes to a stage where we do need to treat, and this is called PDR, is what I'm going to refer to it today, or proliferative diabetic retinopathy. And here you can see the stuft of new vessels that I mentioned forming on the optic nerve head. This is called neovascularization of the optic nerve head. This then bleeds, as these abnormal vessels are very leaky. They're not like the regular structures of the eye. They're leaky, and then it could lead to a huge blood clot on top of the retina. This could bleed into the vitreous cavity, forming vitreous hemorrhage. And then later on, membranes, white membranes can form on the retina. And these membranes, as they contract, can pull the retina and cause a retinal detachment. This is a stage where surgical intervention is essential. Now, diabetic macular edema is when the center of the retina, called the macula, this is very essential for your central vision and for your reading, and mainly for all your activities. And when there's edema formed here, this is when it is definitely sight threatening, and early intervention is essential. So when you have non-proliferative diabetic retinopathy, this is how your vision could be totally normal. You don't even realize you have something going on in the eye. By the time you come to proliferative diabetic retinopathy and there's a bleed in the eye, you could have these floaters, small black dots, wavy lines moving in front of the eye. And when you have diabetic macular edema, that's because the center of the eye is affected, your vision gets blurred or distorted. So do not wait for vision to drop. Please get your annual checkups done, irrespective of your symptoms. Now, screening, as we spoke about it, diabetic retinopathy, early detected, type 2, every year, annual checkups are essential. By the time you start getting moderate, it becomes more frequent, 6 months. Severe and very severe become 3 months. And if it's proliferative diabetic or diabetic macular edema, then as your ophthalmologist, your retinal surgeon decides, you need to go in that frequently. Now, how do you diagnose this? Visual testing, a dilated fundus examination, or optical coherence tomography, or a fluorescein angiography. So dilated fundus examination is where we put drops in your eye, make you sit in a clinic for about half an hour. And then with this instrument called an indirect ophthalmoscopy, we look inside the eye at the retina and see the various stages. Now, how do you realize what is happening inside the eye? So to document this, we take a photograph. This is a fundus camera in which we are taking a fundus photograph. Now, retinal scans are each patient, each person, it's almost like your thumbprint. It's very unique to you. So it's almost, this is Tom Cruise, who's, using his retinal scan to open the door to the safe in the very famous movie, Mission Impossible. So it's something very specific to each person, like your fingerprint. And documentation is essential because you could have a baseline and then follow up to see whether it's worsening every 3 months or 6 months. Now, with the onset of COVID, as Dr. Vishwanathan spoke to us, there's more new diabetics coming in, worsening of existing diabetic patients. So handheld portable photography is very much having an expanding niche, and these can be taken for teleophthalmology, where you have lesser clinic visits. This can actually be taken to the patient's house, and a photograph of the retina can be taken. And this is very easy to handle, and the quality of the images are very good. Now, you don't just need that. Even a smartphone and an adapter put onto your smartphone. Smartphone is something which all of us have, whether in the rural areas, urban areas, and just an adapter to that. And you need it's a low cost, ubiquitous instrument. And the quality of the images are quite good. So the outreach is much more in detecting diabetic mellitus. Now here we are not, maybe the subtle changes may be missed, but the gross changes will definitely be picked up. So what we are looking at in these kind of images are preventing sight-threatening diabetic retinopathy. Artificial intelligence is entered the market in all kinds of fields, and ophthalmology, which is so image based, definitely has a huge role to play with artificial intelligence. And studies have shown good high sensitivity, high specificity with more than 90% in the various algorithms. And this, especially in the era of COVID-19, which is also probably here for some time, artificial intelligence will definitely have a role. So you take a smartphone image, upload it onto the algorithms which are there, and that can help you decide whether you need treatment or not. Fluorescein angiography is the next mode. Now this is invasive. This cannot be done at home, or it needs a specialist clinic. You need you need an anesthesiologist or a physician nearby. What we do is we inject this dye into your arm, and this reaches your eye, goes through your heart and comes to your eye. This takes about 8 to 15 seconds to reach the eye. And what this does is we use the property of fluorescence, which is we excite the dye with the blue light. The dye in the eye absorbs it, and what it gives out is green light. Now this green light, it is then captured by by a retinal camera, the fundus camera that we spoke to you about, and this gives us various images. Now what we look for in fundus fluorescein angiography is hyperfluorescence. That means you can see these spots, small microaneurysms, so many outpouchings out here, which are more than what you would see in the naked eye, abnormal vessels like this, or them bleeding through, leakages like this. Or it could be the opposite, hypofluorescence, where they could be blocked. That means there's no vasculature here, dropout areas, or it could be blocked by the blood in front of it. So hyper or hypo, these are detected. So it's basically like, probably Dr. Manoj would talk about the angiogram that you use, cardiac angiogram, something similar to that. And it gives us areas in diabetic macular edema. It tells us whether the area of leakage is focal, that is, it's concentric to a small area, or whether it's all over the retina, what we call diffuse macular edema. Now, the next instrument that we use to detect and monitor is something called an optical coherence tomography. This is similar to how you would do a CT scan of the brain. This is a CT of the retina. And this is an image of histology. So if you would cut the retina and look at it under a microscope, these are all the layers that you would see, the 10 layers that I spoke about. And this is the OCT image, which gives a near histology kind of picture. And this is how a normal OCT looks. All the lines are straight, and you have a U-shaped dip in the center. Now look at what happens in diabetic retinopathy. This is a 3D topography map using the OCT. Do you see this elevation which is here? So this is what we call diabetic macular edema. And this OCT scan gives us an image from all angles. Unlike a fundus photograph, which is a 2-dimensional, this is 3-dimensional. So it gives you the contour of the retina, and it also gives you the morphology. So what kind of thickness it is, whether there are fluid-filled cavities in the center, pockets of fluid in the center, or diffuse thickening of the retina. If there are membranes within the retina which are pulling onto the retina, causing traction, or whether the entire retina is pulled up, causing a retinal detachment. It can give you focal edema, as I said, just a small area, or whether it is diffuse. You can see those large pockets of fluid here and fluid accumulated in the center. It also gives us, now just looking at morphology may not be enough. We all love numbers. Quantification is important. So it gives us the thickness of the retina. So normal is around 200. Now, if you see 504, you know, obviously the thickness is increased. And this is post-treatment. So this is also very useful to explain to your patients how they are getting better, how treatment is essential, and how it's helping them regain their vision. Now, what's new in this? So we've seen angiography, we have seen OCT. How about we combine both? So you have OCT angiography, but here the difference is there's no dye. So in patients with nephropathy, in certain patients where it's contraindicated, you cannot use the dye because it's invasive. This is definitely a godsend for those patients. So what you get is you see these stuffed of abnormal lacy vessels. This is an angiography which shows leakage. But if you look at this OCT angiography, imagine without injecting the dye, I'm able to appreciate this beautiful vascular network on the optic nerve head. Similarly, this is another vascular network. You see profuse leakage on the angiogram. But if you look at the OCT structure of this, you can see this vascular network. This is another OCT angiography of a patient which shows those dropout areas, areas of ischemia that I mentioned. So imagine getting these images without having to inject a dye. So OCT-A has revolutionized the way we manage our patients with diabetic retinopathy. How do we treat these patients? So non-proliferative is where you need good interaction with your intensivist, your endocrinologist, your nephrologist, with the whole team to make sure that the patient is well controlled. And what you're trying to do is prevent progression into proliferative diabetic retinopathy. But once there is proliferative diabetic retinopathy, that's where we need to intervene with treatment. So the treatment could be laser, injections in the eye, or finally surgery. So what we do for a laser is laser is a procedure where we make the patient sit like this, and through this laser machine, we are putting in some beams of laser into the retina, causing scars and causing these blood vessels, abnormal blood vessels, to regress and prevent further bleeding. So it causes 50 to 60% reduction of the severe vision loss in patients, according to the diabetic retinopathy study. This is now what is new in laser is the multi-spot laser photocoagulation, which we have at Rajan Eye Care. How is this different from your regular conventional laser? So if you look at this short video that I'm showing here, this is the regular conventional laser. The laser beam hits the retina, and this is the amount of collateral damage done. But if you look at the multi-spot laser, is a very short beam. So the collateral thermal effects on the surrounding structure is much less. So you're giving multiple shots in the same sitting, about 20-25 shots in one go. And this forms a pattern. This is a patient with the bleed here, proliferative diabetic retinopathy, and entire retina, pan retina, is covered with laser. Now, so if you look at this conventional laser, this is how it looks. And if you look at a multi-spot layer, this is how. So there's even distribution. You can actually finish this entire laser in one sitting, unlike the conventional laser, which needs multiple sittings. It's more comfortable to the patient. The pain is less for the patients. So it's actually, and as I said, collateral damage is also much less in these patients. Now, this is a patient with diabetic macular edema. You see this whole ring of cholesterol deposition, and then post-laser, you can see how it is absorbed. Now, will your vision become normal after laser? Not really. What we are trying to do is prevent further deterioration of vision, and it reduces by 90% the chances that you may become legally blind. Now, what are the precautions that you would take afterwards? Because you're dilated, your near vision will be blurred after laser. You need somebody to take you home after this. You need to have an attender with you, and you can do all your routine activities, but avoid strenuous activities for about a month post-laser. The next modality of treatment is injections inside the eye that we do under sterile precautions inside the operation theater. And there are various drugs which are available. Some long-acting drugs are implants, steroid implants, which can be left in the eye for till 3 months, and then the effect wears off. So if you look at these cysts before the injection, and then after the injection, the cysts are getting resolved. So OCT helps us even monitor these patients, monitor the efficacy of treatment. Finally, if nothing works, then we go into surgery. And what we have, the latest modality is sutureless. So earlier, if you could see this eye post-surgery, you'll see a knot here, the amount of congestion in the eye, the uneven surface. This is 3 days post-surgery. But if you look at this micro-incision sutureless vitrectomy surgery, the eye looks so quiet. Nobody even knows that surgery has been done in this eye. So this is a short video that I'm sharing. I'm just going to, sorry. So this is the cutter that we insert into the eye. These are the membranes on the retina which are being cut using the cutter. We're trying to release the antero-posterior traction on the retina, the tangential traction. So we have smaller instruments which have come in now, which make us go closer to the retina. So there's less damage, better hemostasis, less bleeding intraoperatively because of the smaller gauge of the vessels. This is cautery being done to prevent intraoperative bleeding. I think I'll just skip this, sorry. Yeah, as we know, eye is a window to the body. So just treating the eye is just not enough. As we said, the whole role of treatment in non-proliferative is to prevent it from going into this proliferative diabetic retinopathy. So prevention is the key, and just treating the eye is inadequate. So along with our intensivist, with our diabetic specialist, we have to make sure that the patient is being well treated. Now, all drugs have the same effect on the retina. However, when you're strictly controlling the patient, initially there may be some amount of worsening, but long term, in about 6 years, it reduces the progression of retinopathy. There are some drugs in patients with diabetic macular edema who don't respond to regular treatment. There are some oral hypoglycemic agents that are associated with an increased risk, like thiaglitazones, and we may ask our physicians to change them if the patient is not responding to our routine modalities. Hypertension, diabetes, retinopathy does progress with uncontrolled diabetic retinopathy. So controlling the BP is very essential. In anemic patients, there can be worsening of retinopathy, so treatment is essential again. These are patients with nephropathy, where you can see that there's more ischemia at the macula, more hemorrhages, a lot of cholesterol exudation at the retina, in the macula, more ischemia in the form of cotton wool spots. So the severity is much more. So if dialysis or transplant is required, then it's the nephrologist's call to handle these patients. Cardiovascular accidents also are higher in patients with diabetic macular edema. And if they've had a recent stroke or a myocardial infarction, then we do avoid some kind of injections in these patients for some time. Dyslipidemia, this is a patient, you can see how the cholesterol is, and after starting his, after controlling his lipids and his triglycerides, you can see that without any other eye treatment, the cholesterol has got absorbed. So patients are more likely to have worsening with dyslipidemia. And the worst part is it all kind of can go to the center of the fovea. It can all gravitate. So that's worsening of vision. So to conclude, it is just not enough to, try and treat the eye. You need different disciplines, different departments for appropriate and effective treatment of diabetic retinopathy. We know there are different agents coming in. So good, consistent communication with the patient about their lifestyle modifications, conversations with their physicians is the way to go in the future. So comprehensive diabetic management is the way to go. Thank you very much, and have a great week. Safe Diwali.
Thank you, Supriya, for the incredible talk. Incredible talk, I would say. You covered everything, and you emphasized the importance of a multidisciplinary approach as far as the management of diabetic retinopathy is concerned. Quick one or two words from Professor Shantaram, sir, because you see a lot of patients with diabetic retinopathy, also diabetic nephropathy, diabetics with cardiovascular disease as well. Yes, sir. One or two words from you, sir, and then we'll go on to the next speaker.
Yes, sir. We know that diabetic retinopathy is the leading cause of blindness next to cataract.
Yes, sir.
So what we have to do to prevent that retinopathy is early diagnosis of diabetes by regular screening, and various landmark trials like UKPDS, DCCT has clearly shown that intensive glucose control in the first 7 to 10 years prevents the complications, even if the control is not good after 10 years. So you should aim for early diagnosis, initial good control to prevent diabetic retinopathy. And as Dr. Supriya said, it's not only diabetes, but the management of the comorbid is also equally important to prevent diabetic retinopathy, like hypertension, dyslipidemia, management of anemia. That is very important. And as Supriya said, diabetes now, they're going to use retina to diagnose the predisposition to the cardiovascular disease. Now they are using artificial intelligence to do that.
Yes, sir.
So eye is a very important organ. So to prevent it, to prevent blindness, prevention of retinopathy is important. So for that, a diabetic should go for regular screening, eye screening, at least every year if it is normal, and if it is not normal, as decided by the treating ophthalmologist, either a 3 months interval or 6 months interval.
Absolutely, sir. I think I fully endorse whatever you say as far as the diabetic retinopathy screen is concerned. We'll talk about the diabetic memory. You mentioned about the diabetic memory, which is very important for the retinopathy, because we'll talk about it during the panel discussion, sir. And I request Dr. Ravi Shankar to introduce the next speaker.
Thank you, sir. It is my pleasure once again to introduce the third speaker of the day. Has been in cardiology practice for 23 years in Chennai. His special interest is preventive cardiology and therapeutic interventional cardiology. He's dedicated to spread knowledge and teach cardiology to many physicians and junior cardiologists by doing continual medical education programs. There's a number now, 18,860 invasive cardiac interventional procedures independently done by him. It's a very big number, Dr. Manoj. And one more to record, holds unbroken academic record of 12 gold medals in his undergraduate MBBS, which no one has broken until today. And also adds on to the feather, one more feather to the cap, another gold medal in his master's. May I have the pleasure to introduce this senior cardiologist and interventional cardiology consultant of Kaveri Hospital, Chennai and IIT Madras. I have the greatest pleasure to introduce Dr. S. Manoj to the August gathering. Over to Dr. Manoj, please.
Manoj, all yours, Manoj.
Well, thank you, Dr. Mohanrajan, Dr. Sujata Mohan, and the organizers of this wonderful evening digital meet. And particular thanks to the introducing guest, Dr. Ravi Shankar, esteemed head of panel, Professor
Shantaram.
Okay. Yeah, Professor Shantaram, and delighted to be part of a great panel of experts in the ophthalmology care, and also extremely delighted to be once again part of this faculties chosen by the Rajan Eye Care Educational Foundation. My task would be to talk about the diabetes and the heart. I think that it cannot be covered in 15 minutes of time, but I will try to do the justice by at least enlightening the importance of taking care of diabetes as well as the heart together. And the subsequent speaker would also highlight on the importance of addressing the renal protection in diabetic patients. We know that diabetes is the most common prevalent clinical disease globally, and you would also see that the cardiovascular disease is the leading cause of death in this population with diabetes. So in another 15 years of time, you would see that nearly about 600 million of people would be affected by diabetes and would be living on this world. And you would also see that people who have diabetes, as compared to those who don't have diabetes, they have an 85% chance of all-cause mortality, and particularly 76% of dying from heart disease by themselves. So you would know that the diabetes and the heart is very closely linked, and there's many diseases of the heart that the diabetes propagates and accelerates. So cardiovascular disease is the most prevalent cause of death and morbidity in the diabetics. You would know that 2/3 of the death among the diabetics are attributable to the cardiovascular disease. And for those common man who have logged in and public who are logged in, I would say cardiovascular disease is the disease of the heart and blood vessels of the human body, where we would address this as a heart attack, heart failure, stroke, and also disease affecting the limbs, causing gangrene and loss of limb. So you would see that in this cartoon, if the HbA1c is 7 or more, you would see the mortality, relative risk of mortality from glycemic control or diabetes is double as compared to having less than 7%. So it's very important that we bring the value less than 7 and maintain preferably at the target goal. Particularly, it doesn't apply widely over all populations with diabetes, but in the most of the populations with diabetes who have less comorbid conditions along with that. So in a middle income country like ours, where you have a large population of the socially protective age group between 50 and 69, you will see they were already had 41% of people with diabetes have had some form of cardiovascular disease in the form of either stroke or a heart attack or a disease of the limbs affecting with the loss of the limb due to the infection or the loss of the limb from peripheral arterial disease and the gangrene. This is a well-known fact that atherosclerosis, where there's a deposition of the cholesterol-laden macrophages and also plaque formation that progressively narrows the vessels all over the body, not necessarily in the heart, but also in the brain, as well as the carotid arteries and also the limb arteries, and causing deficient flow to the particular organ subtended by the artery. And you would see that progressive vascularization of atherosclerosis happens. Compared to those who do not have diabetes, atherosclerosis is very early in onset and also aggressive in its progression to cause early disease onset. So therefore, the diabetes is now considered a risk-enhancing factor of atherosclerosis, and per se diabetes without absence of other risk factors is considered a moderate risk factor for developing cardiovascular disease, which you would see subsequently in my presentations. Particularly addressing the diabetes and the heart, they often have, with regard to the coronary artery disease, they have a diffuse and multiple vessel disease of the coronary atherosclerotic territory. Often they do better with bypass surgery as compared to the angioplasty because of the extensive disease involvement, but those who have undergone angioplasty for multiple vessels in the heart because of the coronary artery disease, they probably will require multiple subsequent procedures as compared to the bypass heart surgery. Also, it is understood that they have a recurrent ischemic coronary events. Despite the bypass surgery or angioplasty and optimal medical management, they often have recurrent events and probably lead to high mortality and shortened lifespan than those without diabetes. So the higher morbidity and acute higher onset of coronary events is particularly seen in this COVID-19 disease pandemic, which we are going through. And in the absence of coronary artery disease, we often see many patients coming with acute coronary syndromes, particularly in diabetics, who may not have coronary artery disease, but can still have high thrombotic tendencies because of the inflammatory process, which is rampant with diabetes as well as in the COVID-19 disease. Now, if you see that it was conventionally known that the coronary artery disease causes predominant mode of death in patients with diabetes, which is not so in the current generation of our understanding. So coronary artery disease is increased by twofold. The stroke risk is increased by twofold, But what is understood now is the heart failure is a very, very common condition which is associated in people with diabetes, even without the absence of coronary artery disease or other associated risk factors. And that is also increased multifold. So you would see that in the Swedish National Diabetes Registry, you would see that the prevalence of diabetes as well as the prevalence of coronary artery disease or the mortality from coronary artery disease, even though it's trending low, there is still a parallel, almost double the risk of dying from cardiovascular disease among the diabetes as compared with those who don't have diabetes. And the death from coronary artery disease in diabetics is again double. Hospitalization for various forms of manifestations of cardiovascular disease among the diabetes is again double. So just mere presence of diabetes in you itself increases the preponderance and the risk of developing various cardiovascular disease manifestations quite early, and also having a higher risk of morbidity and mortality. The various manifestations, as I said, the key manifestation is the heart failure and the coronary artery disease causing angina, and also acute myocardial infarction, and also sudden cardiac death. So this is a small study of around 386 patients who had type 2 diabetes mellitus and who had gone through a stress test at the baseline with no inducible ischemia. That means they did not have any coronary artery disease or heart failure at the baseline. And then they were followed up for 5 years, and they did a baseline follow-up echocardiogram. And you will see at 5 years, only 32% of patients had a normal left ventricular function, and almost 68% of patients with type 2 diabetes mellitus who didn't have any evidence of ischemic heart disease at the beginning of the study had some evidence of left ventricular dysfunction or heart failure 5 years after diabetes mellitus. Whether it is a systolic or a diastolic heart failure, both combined, it's almost 68% in patients who have a diabetes mellitus. This is a very eye-opening study from Anish Shah and Anup Shah from UK, and he found that a follow-up of almost 1.9 million of people with type 2 diabetes mellitus who didn't have any cardiovascular disease at the onset, and they were followed for the incidence of various manifestations of cardiovascular disease for the next 5.5 mean follow-up years. And they found that peripheral arterial disease is the most commonest manifestation of cardiovascular disease, followed by heart failure, as compared to what we understood all along was the myocardial infarction, stroke, and cardiovascular death. So this is a very, very important study which came in 2015, and that made us understand that peripheral arterial disease and heart failure is the most commonest manifestations and is often missed in patients because the focus in all the studies has been only on myocardial infarction, stroke, and mortality. So this was a very, very important study, and that's why heart failure has become a focus of discussion, and also a search for evidence and science of symptoms of heart failure in patients with diabetes mellitus. So all along, as I said, people were looking at the microvascular complications in the form of myocardial infarction, stroke, and peripheral arterial disease, and microvascular complications in the form of retinopathy, nephropathy, and neuropathy. But what was missed and forgotten was a frequent and most fatal condition called the heart failure. And this is the most commonest manifestation in the diabetes as per the large population which was followed up for the manifestations of heart disease. And you would know that the heart failure has the most gruesome and the highest mortality as compared to any other forms of cancer that we know of currently. So the heart failure 5-year death rate is almost close to 50% as compared to most of the other cancers. This is our own study from the Trivandrum Heart Failure Registry, which showed that 55% of patients hospitalized for heart failure had diabetes mellitus. So that is the prevalence, and diabetes mellitus, presence of diabetes mellitus increases the chances of developing heart failure. So the diabetic cardiomyopathy by itself has become a significant entity, even though many of the scientific committees like the ACC, American Heart Association, European Society of Cardiology, or American Diabetic Association haven't yet defined what is diabetic cardiomyopathy. But this is a very distinct entity that we come to see now, and perhaps we can define diabetic cardiomyopathy as the existence of abnormal myocardial structure and performance in the absence of other cardiac risk factors such as coronary artery disease, hypertension, or significant valvular heart disease in those individuals who have diabetes mellitus. So the heart can get affected in multiple manner. I wouldn't go into that. The scope of discussion will be huge if we look into how, in what format the diabetes and heart gets affected significantly. But something I would touch upon, what is called the AGE. It's not the age of the patient, but it's the advanced glycosylation end products. And you will see that the age, advanced glycosylation end products gets deposited in the tissues and causes various dysfunction and late complications in the healthy tissues, even the skin, the nail beds, and also the myocardium, and also various other systems in the body can get affected. What is the simple manifestation of that? The clinical signs of accumulation of the advanced glycosylated end products in the tissue causes rigidity and stiffness of particularly the hands and the digits and the fingers, and causes a limited joint mobility. So when you apply the print of the palm, you will see the controlled non-diabetic person could apply it properly, whereas the most part of the hand is missing in the print of the palm. And this is probably called the prayer sign. You will see they cannot oppose the both the fingers and the phalanx are all rigid and stiff enough, and there is a flexion deformity. So these are some of the simple clinical measures by which we can understand that there's an advanced glycosylated end product deposition, which can happen even in the myocardium. However, the good news is that we have an effective treatment for diabetes, and you heard it from the original researchers and the pioneers in the field of Indian diabetology, Dr. Vijay Vishwanathan, and also all the important diabetologists that we have on the panel. And we have a good compliance to diet, exercise, and medications is very, very important. And that's where we have to bring in a very close cooperation with the patient and the family that looks after the patient, and continue to maintain this compliance at every visit. We have to drive on this important point to have a sustained benefit from the therapies. Effective medications to protect and prevent the heart disease, heart failure, and kidney disease is now available. You have ACE inhibitors, ARBs, and also RNAi in those with heart failure. Statins are an important aspect of management and prevention of heart disease and also cardiovascular disease in diabetes. SGLT2 is a new kid on block. It's got a spectacular and very remarkable response to preventing heart disease, heart failure, and also kidney disease. Periodic test is required to detect any kind of target organ damage, and there needs to be very close multidisciplinary cooperation. So currently, all medications, it is mandatorily required that medications used or to be introduced for the treatment of diabetes should go through a multi-center randomized trial, and to show that they are safe or neutral or reduce the risk of heart-related events. And this is very particularly important because of the FDA requirement, and this has become a mandate now for all kinds of pharmacological agents used in the treatment of diabetes. So you have a GLP-1 receptor agonist and also SGLT2, which is the most important class 1A drug, which is a choice along with the metformin to reduce the cardiovascular risk in diabetes. Many DPP-4 inhibitors are also neutral, and there are some of them like saxagliptin are not to be preferred in those with heart disease. So majority of them are neutral and safe with regard to the risk of heart and related disorders. Sulfonylureas are less preferred. Perhaps in our population, the appeal is because of the cost of the therapy. However, there could be a weight gain with the use of sulfonylurea and drastic hypoglycemia if it's not appropriately controlled. So this is the SGLT2 statement by the American College of Cardiology in 2019, which showed that SGLT2 inhibitors have robust effect in reducing the risk of heart failure, which do not appear and is independent of the atherosclerotic risk and prior heart failure and renal functions. And therefore, it has become a class 1 level of evidence A indication. That means almost every patient with diabetes should receive this drug if there is an indication for reducing the risk of heart failure hospitalization in patients with diabetes mellitus. So that's the scope of introducing this molecule. If you see those, there are two types of patients with diabetes with multiple risk factors, patients with diabetes and who already developed a myocardial infarction, stroke, or a heart failure. So this is a cardiovascular disease with established in patients with diabetes. And these are the patients with multiple risk factors and diabetes who yet to develop any kind of cardiovascular events. So when you introduce SGLT2, the major adverse cardiac events like the heart failure, the stroke and myocardial infarction and the death reduces in those significantly with diabetes and cardiovascular disease. And across all the patients with diabetes, whether they have established cardiovascular disease or only multiple risk factors, and even in the absence of cardiovascular disease, all patients with heart failure, the SGLT2 reduces the onset of heart failure and hospitalization for heart failure. Again, the renal disease, you would hear from Dr. Ram Prabhakar that it is significantly and spectacular reduction if introduced very early in the disease process. So when it comes to diabetes and heart failure and heart disease, you have to address what is called the hypertension, and you would see a significantly the diastolic goal of blood pressure as less as possible, less than 80 would remarkably improve. So there is a significantly greater benefit with more intensive blood pressure control in diabetes as compared with those who do not have diabetes. When you touch upon the lipids, this is the update from the European Society of Cardiology in 2019. They have classified patients with diabetes into two groups, those with no additional risk factors and with a diabetes duration of less than 10 years. So just a simple presence of diabetes of less than 10 years makes it a moderate risk for heart disease development or cardiovascular events in future, and their LDL goal should be less than 100 milligram per deciliter. The second group is those with diabetes mellitus exceeding 10 years or having multiple additional risk factors. In the absence of target organ damage, they are categorized as the high-risk group, and their LDL cholesterol should be less than 70 milligram per deciliter. The third group is those diabetes mellitus patients with the target organ damage or with the duration exceeding 20 years or with 3 more risk factors. They are the very high-risk groups, and they should have the LDL cholesterol reduced less than 55 milligram per deciliter. And this is the role of aspirin, which is often prescribed by many of the practitioners on diabetic patients. But many of the studies of almost meta-analysis of 9 studies have shown that aspirin does not provide any cardiovascular benefit in diabetics for the primary prevention. What is important is to address the cardiovascular risk reduction, appropriate therapy of glycemic control, appropriate reduction to the target goal of blood pressure reduction, and also look at the statin, appropriate dose of statin. Along with that, we need to continuously educate for healthy eating and adequate physical activity, persistent, continuous monitoring systems and screening for various high-risk populations for any target organ damage, control of hypertension, and prevent the use of tobacco in the patient. So what are the numbers that patients should look at when they have a diabetes and heart disease? The HbA1c should be preferably brought to a goal of 7% or less, but not less than 6.5%. Blood pressure should be targeted to 130/80 or less. LDL cholesterol preferably less than 70 milligram per deciliter, and the body mass index should be very importantly maintained 25 kilograms per meter square. So diabetes licks the body everywhere from head to foot, and bites the heart very, very hard. We can work hard and beat the diabetes. Thank you for being a part of this important symposium. And I should thank the Rajan Eye Care Foundation immensely for the opportunity given to address on this topic of diabetes and heart. Thank you.
What an amazing talk, Manoj. It was really a fantastic talk, and you have covered each and every aspect of the cardiovascular disease. And I'm also, because I've seen you right from the beginning of your practice, I'm also amazed at your growth. And you've become one of the top interventional cardiologists in the city of Chennai, not only city of Chennai, in this part of the country as well. Hats off to you, Manoj. It's because of your competence, I think, and because of your effort also. And
thank you for words. Thank you, kind words.
Thank you very much. Sir, I want your quick input on Dr. Manoj's talk, sir. Shantaram.
For the elegant lecture on diabetes in the heart, highlighting the various ways in which diabetes affects the heart and the interventions to prevent the diabetic heart disease. We all know that diabetes drives the cardiovascular epidemic, and cardiovascular disease accounts for 2/3 of the deaths in diabetics, and 75% of them are premature deaths in diabetes. So, one, it affects coronary artery. And the worst thing about the coronary artery disease in diabetes is it is silent, more diffuse, multivessel, leading to recurrent coronary events. And following restenosis, there is a very high incidence in diabetes, so CABT, is the treatment for coronary artery disease, especially when they have double SL or triple SL with diabetes. And he has rightly pointed out that one of the commonest manifestations of diabetes, heart failure, has been missed all these years till the advent of the SGLT2 inhibitors. It is so common, heart failure in type 2 diabetes. Now, diabetes is considered as a stage 1 heart failure. And this gives the answer to Dr. Sujata's question on the first line of drug in diabetes. At least in the subset of the patients with atherosclerotic cardiovascular disease and early kidney disease, SGLT2 can be used as a first line drug, especially in patients who are metformin intolerant.
Okay, sir. Thank you very much. I think SGLT is probably becoming a wonder drug because it it's a cardioprotective as well. It's also kidney nephroprotective as well. So, and something which is news for all of us is Manoj's talk has opened up Pandora's box, because we all thought that silent heart attacks are more common and more dangerous. But you say that diabetic cardiomyopathy leading to cardiac failure is more dangerous and more common as well. And that's been underdiagnosed. That's what they say. We'll come to the panel discussion. I request Dr. Ravi Shankar to introduce Dr. Ram Prabhakar.
Thank you once again, sir. And prior to the program, Dr. Mohan Rajan was mentioning that Dr. Ram Prabhakar is one of the youngest nephrologists in the country today, and by his looks, but Ram Prabhakar actually is too large. Let me quickly read out his profile: MBBS, MD, DNB General Medicine, DNB Nephro, DM Nephro, MNAMS, MBA, Fellow of American Society of Nephrologists, FRCP, FACP, and FIM-SA, and it continues. I don't have time. And he's got a vast 15 years of experience in nephrology, former Associate Professor of Nephrology, SRM Institute of Medical Sciences, Katangulathur, and also the former Associate Professor of Nephrology from Sri Ramachandra Medical College University, and has 14 publications as a first author in international and national journals. That's a great thing, Dr. Ram. And presently, Director, Senior Consultant, Department of Nephrology, SRM Institute of Medical Sciences, SIMS, Chennai. May I have the pleasure to introduce to the audience Dr. M. Ram Prabhakar.
Over to you, Ram. All yours.
Let me share the presentation.
Yeah, please share your screen.
Yeah.
Yeah, we're able to see your screen.
Yeah, sure. Good evening, everyone. I will begin by thanking Dr. Mohan for the opportunity and including me in this August panel. And it's a huge honor to be among elites in diabetology. I have to thank Dr. Ravi Shankar for wonderful introduction. So this topic I am going to speak about the facts and figures about diabetes and kidney disease and how to diagnose and what is changing in epidemiology diabetes. You have heard from the cardiologists that they are moving from heart failure to, from coronary artery disease to heart failure. Likewise, there are significant changes in epidemiology of kidney disease in diabetes. And I'm going to concentrate more on the basic part about prevention of progression and early diagnosis. I'm not going to concentrate on much on treatment because of the time constraints as well as the nature of the audience. So facts and figures, we know that the incidence of kidney disease is increasing worldwide. Otherwise, I think person like me will not be a part of such a panel. If you look at the numbers, it is almost chronic kidney disease affects 11 to 13% of the world population. And the important thing is not this number, but the impact it causes. It causes tremendous amount of morbidity, mortality, and the loss of disability adjusted life years. And the predominant reason for the impact of chronic kidney disease is diabetes and increasing aging of population, use of many nephrotoxic drugs, and of course, early recognition of kidney disease in diabetes. If you look at this published data 2 years ago, you know that the incidence of chronic kidney disease is going up by 90%, prevalence is going around 90%, death due to chronic kidney disease has come to 98%. But if you look at the published data, now they say chronic kidney disease is almost like 8th common cause of death across the world. And the predominant drivers of this is diabetes. So that's what we need to understand. So diabetes is the leading cause of end-stage renal disease as well as chronic kidney disease throughout the world, including in India. This is the message I am giving you. If you look at cause of chronic kidney disease from the published data, this is the data from the US, which says around 38% have chronic kidney disease. Of all etiology of chronic kidney disease is due to diabetes. From the India, we have around 31% of our chronic kidney disease population is due to diabetes. But if you look at as a end-stage kidney disease population, I have put in the left side the US data, 46.9% population, and I have put our own data. This is the current prevalent dialysis population in our center. You can look at that. It's almost 45% of our dialysis population is diabetes. So what you could sense is, although the chronic kidney disease incidence is relatively less, they do progress quite a bit and they require renal replacement therapy at much higher rate compared to other causes of chronic kidney disease. Prevalence of kidney disease and diabetes in India, I have chosen this particular study because the definition of chronic kidney disease has underwent a change. There is not much of the older data doesn't follow the definition of the present definition of chronic kidney disease. So this is a nationwide analysis of around 3,000 odd patients where they used the definition of albumin creatinine ratio and estimated GFR, which are the current standard to define chronic kidney disease. You can see 48.4% had chronic kidney disease among all diabetic population. And quite importantly, almost like 1/4 of them, 25, close to 24% of them had stage 3 and beyond. That is means a significant chronic kidney disease. And you look at this, almost 0.7% of these diabetic population had end-stage renal disease. That's quite a number. So if you put these numbers into perspective, but unfortunate fact is neither practitioners nor patients seems to be aware of this number. I'll tell you, this is the data from the US. 40% of US family physicians fail to recognize chronic kidney disease. Only 54% identified albuminuria as presence of kidney disease. Even in India, this is the data from AIMS. So they looked at people who had investigated for kidney disease in diabetic population in diabetic OPD. You can say that 54.4% have never been investigated for kidney disease among diabetic population. This is all real published numbers in the recent years, not even old. This is just 2 years ago. You look at among practitioners, only 45% were aware of their kidney function among practicing physicians. And only 1/3 of them correctly identified diabetes as a risk factor for chronic kidney disease. This is again an Indian data published a year ago. So that's the real numbers we are living with. So if you want to know the exact numbers, you can see the data from IDF says the prevalence of diabetes in India is almost 1 in every 11. That means around 9% of our population have diabetes. So if you put that in numbers, it's around 77 million. Unfortunately, unlike in the US, we don't have exact numbers of diabetic kidney disease. So if you extrapolate this number based on the prevalence, you have close to 34.56 million diabetic kidney disease. Almost like 3 crore population have diabetic kidney disease among our population, and quite a bit in-stage renal disease due to diabetes. So that's the impact what we have at the moment. So what people should understand is treatment of diabetic kidney disease is very expensive. This not even many physicians realize. By the time they have a relative with end-stage kidney disease, they understand how much it has havoc in their family. So this is the numbers you can see. When you compare a complete simple diabetic, the cost in dialysis is 20 times higher. If you look at transplant in the first year, it is 10 times higher. If you look at even follow-up therapy of transplant, it is 5 times higher than simple diabetic care. So it is very important to recognize kidney disease and treat it early so that you don't land up in advanced kidney disease. Again, this is a real published numbers from Indian Journal of Nephrology, which are just 7-8 years ago. You can see the average cost which is spent on hemodialysis and peritoneal dialysis a month. The total cost in hemodialysis population is close to 35,000. If you look at peritoneal dialysis, around 35,000 per month. So not many people can afford this care of renal replacement therapy or end-stage kidney disease in diabetic population. Not only this care is a problem, the outcome itself is a problem with end-stage kidney disease. It's not very great. I will show you some numbers. You can just see the data from survival on hemodialysis at 60 years. You can see in Brazilian dialysis population, we lose almost 60% of them. Only 40% had 5-year survival among diabetic population compared to close to 80%. So you get almost double loss of lives in diabetic dialysis population. That's very important. If you look at even the numbers in transplant, when compared to diabetic versus non-diabetic transplant, there is a significant difference in terms of graft survival, means the kidney survival, as well as the patient survival. So both had significant difference between diabetic and non-diabetic recipients. That's why nephrologists always hate to see diabetic patients, because you know that these fellows are not going to do well compared to a non-diabetic individual. So what I am trying to emphasize here by looking at or showing you all of these numbers, that it is the detection and early care that saves lives, and it is cost effective. It can be done with little effort and less cost. Only thing you should be aware, RRT is very expensive and not many can afford. Even many of us cannot afford kind of renal replacement therapy of 30,000-40,000 a month for a long period of time. So that's what I am trying to emphasize. But the diagnosis of kidney disease is very simple. It doesn't involve big rocket science. It just involves measurement of urine albumin excretion rate and estimated GFR. Not many people do this in their day-to-day practice. So my idea is to just emphasize on how to diagnose kidney disease. Why should you look for this kidney disease in this population? So how to define kidney disease in diabetes? Kidney disease in diabetes is diagnosed by persistent presence of albuminuria, lower estimated GFR, by presence of markers of kidney damage in terms of anatomical abnormalities or an abnormality in the blood or urine or a pathological abnormality. To give you an example, a person need not have albuminuria, they can have a normal GFR, still they can have chronic kidney disease by abnormalities in imaging. Like for example, in a polycystic kidney disease, they can have normal GFR. So you need to look at all these to define chronic kidney disease. Why albumin is chosen? Not many people know that now albumin has become a standard. People keep still doing protein creatinine ratio, looks for proteinuria, because now albumin is taken as a standard. This is the principal component of urinary protein, and this is the first thing that to change when there is a diabetic kidney disease. When there is a change in the capillary permeability, the first one that comes out is albuminuria, and there is quite a bit of data which says albuminuria causes or linked to a poor outcome. When you compare albuminuria to total protein assays are many times imprecise and insensitive, and there is a huge sample-to-sample variation, and there is a significant interference with so many substances in the blood as well as in the urine. That's why people now started looking at albumin as a marker of kidney damage in diabetes. How to detect albuminuria? It is recommended to do a random spot urine albumin creatinine ratio. People continue to do 24-hour collection, timed collections, but it is not at all needed. Just you need to do a random spot sample. Again, we are insisting on random spot sample because many times people say early morning sample, second morning sample, third morning sample. So there is always confusion among practitioners. So don't forget that just a random spot urine albumin creatinine ratio is enough to diagnose kidney disease in diabetes. You need not have a 24-hour sample, but a single sample is not enough because there is many other causes of albumin excretion is there, like when you exert and give a sample, when you have a very poor control of sugars, when you have a poor control of blood pressure, all this can give rise to albuminuria. So you need to have 2 out of 3 samples within 3 months period to have albuminuria. That's why what I meant as persistent albuminuria. So it correlates with adverse cardiovascular as well as renal outcomes. So once you detect albuminuria, so this is measured by a test called immunoturbidometry. All these things are very important to establish, because this only helps in labeling somebody as having kidney disease. So it should be done by a proper method called immunoturbidometry. It should be expressed in milligram per gram of creatinine. And it is not advisable to do a reagent strip testing, which is done routinely in many hospitals. You should do this test by doing this particular method. About how to classify albuminuria. Albuminuria is classified into A1, A2, A3 categories depending on albumin creatinine ratio to less than 30, 30 to 300, and more than 300. Previously, I highlighted the red one, the A2 category, which was called microalbuminuria. So this term microalbuminuria has become obsolete and it is no longer used because of the simple reason it is misleading. Because many people think micro means something small. So they never understood that it has a huge impact on cardiovascular as well as renal risk. So that is why the term microalbuminuria has been taken off. This actually reflects almost 3-fold the normal albumin excretion. It is no longer a microalbuminuria. Even within this normal range of urine albumin excretion from 10 to 30, there is a difference between increased renal and cardiovascular risk. That's why people removed this microalbuminuria and started using moderately increased albuminuria, or A1, A2, A3 categories. Why cut off at 30? This many physicians used to ask us, because this has been the one which is studied in this large meta-analysis of CKD prognosis consortium. They looked at this number has been associated with more complications of chronic kidney disease. So what do you do after establishing albuminuria? It's not enough if somebody has albuminuria alone. You should quantify kidney function by measurement of GFR. Measurement of GFR, as you might have said in your undergraduate days, is done by a method called inulin clearance, which is the reference standard, which is not practically feasible in our setting. So what researchers have found is estimating GFR based on estimation equations are found to be as good as measurement of GFR by inulin. So the present standard for measurement of GFR is an equation called CKD EPI equation, which has major, the equation looks very complicated, but only few inputs are needed. You need a serum creatinine, you need the patient's age and the patient's gender. From these things, based on this equation, GFR is estimated, and it is routinely recommended to be reported from labs. I will show you how it should be. And this measurement of estimated GFR requires reliable serum creatinine measurement. So there is a huge variation in measurement of serum creatinine. I would say our patients used to come from X lab to Y lab, that this creatinine is this much, that much, why there is so much of variation. We keep on saying that there is not much of standardization that has happened in serum creatinine measurements, but there is a clear reference material and there is a definitely method that should be used when you measure serum creatinine. May not be very interesting to you to understand, but there is a method called IDMS method, isotope dilution mass spectrometry method, that should be the reference method to calibrate your creatinine. So eGFR routinely should be reported along with creatinine. That's what all our International Society of Nephrology says. So thus I have highlighted our own lab report of serum creatinine. You can see the next to serum creatinine, there is a eGFR. I'm just highlighting it. But it should be taken with certain caveats in mind. That's why we have put it as how it is calibrated and how it is variable. All that has to be mentioned in your lab report. So that's how it should be reported. So that only will give you an understanding about routinely looking for kidney function tests in patients with diabetes. So this is how you classify diabetic kidney disease. One extent, you look at the staging G1, G2, G3, G4, G5, and the second one, it is A1, A2, A3, based on what is the albumin. So this is the one which helps in fitting into which stage the patient belongs to. As we move down to the right side, you get more and more severe kidney disease when you get higher albuminuria and higher and lower GFR. So when will you order this test? This is again a common question. Many times what you need to understand is kidney disease in early stages are asymptomatic. Only way to diagnose kidney disease is by doing a screening test, because many times people will say, I am all along normal. How are you saying I am having kidney disease? People refuse to believe and understand. They keep going from X clinician to Y clinician when somebody has been told that they have a kidney disease. So the screening for diabetic kidney disease has to begin in all patients with type 2 diabetes at onset, and anybody with diabetes and hypertension at onset. And in type 1 diabetes alone, it can start 5 years duration of onset of type 1 diabetes. And once it is negative, you should keep monitoring it by once in a year, random spot urine albumin creatinine ratio, as well as measurement of serum creatinine and estimation of GFR based on CKD EPA equation. This is what you should go into every diabetic practitioner's mind. So we generally diagnose diabetic kidney disease by typical presentation of the disease, majority of the time by clinically, by looking at whether they have albuminuria, they have an estimated GFR, when they have a long duration of diabetes, many times concomitant retinopathy, and a gradual progression of kidney disease. So this is the typical pattern when we used to see long years ago, but now it is not so. Kidney disease in diabetes is not always diabetic kidney disease or diabetic nephropathy. All patients with diabetic nephropathy won't have typical features. If you have any atypical features, you should look at getting an early renal biopsy to rule out a non-diabetic kidney disease. So to put things into perspective, there is a huge change in epidemiology of diabetic kidney disease. It is more common than what we thought. So if you look at the books which I have read, it's around 20%, but the present data says comes around 40-45% in most of the studies. Previously used to say nephrotic syndrome is quite unusual. Now they say massive proteinuria many times happens. On the other hand, you also see a spectrum of patients where you get more non-proteinuric kidney disease, more patients having bloods in the urine. Then many patients don't have associated retinopathy, especially in type 2 diabetes. And we get more and more non-diabetic kidney disease. And gone are the days when we just presume presence of diabetic kidney disease in everyone. We may need to biopsy many and more these patients, especially when you have rapid progression with kidney disease. This is what I meant. Non-proteinuric diabetic nephropathy has been increasingly reported, and it has been mentioned as the caption that diabetics when it doesn't read a textbook in most of these cases. So you may miss until and otherwise if you also look for estimation of GFR in them. If you do just a protein estimation, you may miss. So you have to be careful to look for both to diagnose kidney disease. This is numbers to show you the presence of normal albuminuria with kidney disease. Just highlight stage 4 and 5 kidney disease is there even with normal albumin excretion in this particular study called a demand study in almost 30% of patients. So just don't get fooled by normal albumin excretion rate. We always do estimation of GFR along with it. That's what message I'm giving you. And the term diabetic kidney disease is preferred more and more than diabetic nephropathy because of the fact that diabetic nephropathy looks like more of a pathological diagnosis with a typical disease. So if you look at diabetic kidney disease, that's actually a spectrum of diseases involving any form of kidney disease in a diabetic patient. Whereas diabetic nephropathy is a prototype kidney disease in diabetes when they have a typical proteinuria. When you do a biopsy, they have a typical nodular or diffuse glomerulosclerosis when they have associated retinopathy, and they have a gradual progression to reduced GFR. Whereas in diabetic kidney disease, many times they may be non-proteinuric, they may not have retinopathy, they rapidly progress sometimes to chronic and end-stage kidney disease. Whereas biopsy-proven non-diabetic kidney disease are increasingly reported in diabetic population. In most of the published series is around 30-40%. I will show you one among the series. So about natural history of diabetic kidney disease, this is what not many people accept and understand. Many people drop out, they keep hopping from hospital to hospital. What you need to understand is CKD, irrespective of the cause, is a progressive disease. So every patient who comes to us will ask for a medicine to reduce creatinine. We don't have such a magic bullet in most of our patients. What we need to understand, it evolves through stages and resulting in end-stage kidney disease, and most of them requiring renal replacement therapy. The rate of progression of individual disease varies, and we have certain kind of risk factors to identify these people who are going to progress compared to people who are not progressing, and people are looking at identifying and devising molecules to target these pathways. But what we understand is, in general, type 1 diabetes has a fixed pattern of progression. We always say that as Morgan's and stages of progression of diabetic kidney disease, whereas in type 2 disease, it is quite variable, quite variable. So why this concept of renal disease progression is important? We as a nephrologist are interested in preventing progression of kidney disease rather than providing end-stage kidney care. It is very frustrating to provide end-stage kidney care alone in patients with diabetes. We look at trying to preserve kidney function as much as possible by years together so that they can avoid getting into a renal replacement therapy. This graph just says what the rate of progression of kidney disease. When somebody has an onset at 25, he is going to land up quickly in end-stage kidney disease if the progression rate is 5 ml compared to a person who has 1 ml per minute per year. So if this fellow is alive even at 75, if his progression is 1 ml per minute per year, he is never going to land up in end-stage kidney disease throughout his life. So my aim, or our aim as a nephrology community, is to keep this disease from progressing at a slower rate so that you won't land up in renal replacement therapy. And progression in diabetic kidney disease is kind of very severe, especially more so when patients have associated proteinuria. Just a comparison study comparing diabetic versus non-diabetic, proteinuric versus non-proteinuric. So this is the olden data, so they have used the term proteinuria, but in general, any diabetic with albuminuria has a faster rate of progression compared to a person without proteinuria. And there is a variable rate of proteinuric kidney disease also. It's not a fixed pattern that we have seen in many patients. Even some patients we do biopsy and say they are progressing, and just it will show only a diabetic nephropathy. This is a group of patients where they have proven by biopsy in all diabetic proteinuric kidney disease and showed so much variation in their disease progression. So not everything is the same. So we have to individualize and monitor them to identify people who are progressing compared to non-progressors. Prevention of progression of kidney disease is a big challenge in nephrology. That's why we are looking at using glycemic control, blood pressure control, reducing proteinuria with various kind of drugs, prevention of AKI, and providing dietary modifications to reduce progression of kidney disease. For the want of time, I'm not going into the details of all these things, but to summarize, what you need to understand is diabetic kidney disease is very common. It goes up to 40–50% of your diabetic population. It is not recognized at least in half of your population. It is important to understand it increases immensely your cardiovascular risk as well as your disease progression to end-stage kidney disease. And our goal is to prevent its progression by using various measures like drugs like renin-angiotensin inhibitors, SGLT2 inhibitors, and some dietary measures. And providing renal replacement therapy is not the goal, but it is the last option. But whatever you do in diabetic population compared to non-diabetic population with kidney disease, the outcome remains still poor. We have a long way to go. With that, I end my presentation. I thank you very much for the opportunity.
Beautiful, beautiful, lovely, lovely. Ram, I think it's a really an incredible talk. And you have covered each and every aspect of diabetic kidney disease. And for people like us, and we knew that the diabetic nephropathy is different from the diabetic kidney disease. And that's something which EGFR has become the gold standard as far as the pathogenesis or the pathology of the diabetic kidney disease is concerned. And because as ophthalmologists, we got very close relationship with the nephrologists. We got an affinity for the kidney. You know, retinopathy and the nephropathy go in, or the diabetic kidney disease go hand in. You say the diabetic kidney disease need not have retinopathy at all. The nephropathy, definitely they will have some evidence of nephropathy. So that's the reason why I thought we'll open the panel discussion. We'll ask Professor Shantaram about his remarks on this, and then we'll probably cover the kidney disease, and then we go backwards. Then we go to the heart, and then go to the eye.
Thanks, Dr. Ram Prabhakar, with the excellent lecture
Thank
on
you.
diabetes and the kidney, highlighting the magnitude of the problem of the diabetic kidney disease and the huge economic burden it places on the individual and the society. Nicely highlighted how to screen for the diabetic kidney disease and what we should do to prevent the end-stage renal disease, which places a huge economic burden on the individuals and the society. The take-home from this is diabetes is the leading cause of renal replacement therapy. In diabetics, hyperglycemia initiates the damage, whereas hypertension drives the progression. Up to the stage of A2, albuminuria, it is reversible with strict control of glucose and blood pressure. Beyond that, glucose control does not influence the disease progression. It is only the pressure control and the control of other comorbidities, diet, everything plays a huge role. We also know that diabetics have non-diabetic kidney disease in their spectra, and not all diabetics will have proteinuric diabetic nephropathy. As you have highlighted, 1/3 of them have non-proteinuric diabetic nephropathy. And once again, the discordance with retinopathy and nephropathy is especially seen with respect to type 2 diabetes, whereas in type 1 diabetics, they are more concordant, retinopathy and nephropathy.
Absolutely, sir. I think you have got all the points. Let's ask our panel. Manoj Khatri, Sujata, and Ramya, you have anything to say? Because we have got some relationship with the nephrologist. So, you have anything to add?
Fantastic talk by Dr. Ram Prabhakar and Dr. Manoj and Supriya as well. I think there are so many questions that it's very difficult to say one thing, but I think it's given a very beautiful coverage about how important it is to take care of your diabetic status and also the newer medicines which Dr. Vijay Vishwanathan mentioned. The other important thing is that one important factor which I think Dr. Ram Prabhakar mentioned was not to look at only the microalbuminuria, but also to do the spot test, if I'm right about what I'm saying. So I think these highlights are very important from the physician point of view, because we do see like a crossover of patients who are diabetic with kidney disease as well as with retinopathy. So these are some important factors that will be helpful for us to guide the few patients.
Yes. Anything else? Manoj Khatri?
Yes, sir. Sir, a couple of points, what Dr. Ram's talk, especially very interesting talk, sir, Dr. Manoj and Dr. Ram, both of you. We see a lot of patients who are on frequent dialysis, and also they come with frequent bleeds in the vitreous, what we call as a recurrent vitreous hemorrhage. Very difficult to manage this patient because in one go we cannot operate them because we don't get fitness, and the second go, as and when the dialysis keeps progressing, or even the kidney disease worsens, the bleeding in the retina becomes quite complicated. Any thought process of managing this patient, sir? You will advise something for the retinologist to look for?
Then I just like to add to Manoj's question. So we ask these patients usually pre-operatively to try and go for a heparin-free dialysis.
Yeah.
Is it something you all do routinely, or you all don't like to do it, or anything like that? Any contraindication for that?
Actually speaking, many of our patients before started on renal replacement therapy will undergo a detailed retinal examination. The problem is the compliance of the patient. Sometimes they just crash land where you cannot wait. So in general, actually a good scientific practice will be to do a preemptive screening and try to treat the retinopathy much before you put them into dialysis. Because heparin-free dialysis is very, very difficult to do in the long run, mainly because it affects adequacy of dialysis. Because although there is no clot, there will be a microfiber clotting in all dialysis settings. So it definitely affects the adequacy of dialysis. So nobody wants to do it. And even the patient will get angry if there is a clot and he loses 200, 250 ml of blood in the dialysis session. Entire dialysis circuit will get clotted when you do completely heparin free. It's very difficult to do. It is very easy to do for a day or two, or maybe 2-3 settings. May not be feasible to do in the long run.
No, it's a valid point, because what Manoj Khatri and Supriya were mentioning, that because we have seen that recurrent bleeds even in a well-ablated retina. Okay, well-ablated retina, these patients, when they go for dialysis, they come with recurrent bleeds, vitreous hemorrhage. Every time there is a vitreous hemorrhage, what happens? There is a fibrosis which pulls the retina and produces a tractional retinal detachment. So that is the reason why we asked that question. So you're not in favor of heparin-free dialysis?
So it is not possible to do, sir. And not only that, you are only actually blaming heparin. But what we have understood in our practice is there is a general bleeding tendency in uremia. What we call as there is a uremic bleed. This uremic bleed actually happens in every organ. You have in fact, the commonest bleeding happens in the gastrointestinal tract. So there is an occult GI bleeding that keeps on going in many of our patients that contributes to anemia also. So the only treatment for even uremic bleed, because the uremic bleed has so many mechanisms. The predominant is the qualitative platelet defect. It's not quantitative. If you do a platelet assay, it will be normal. But these will have abnormal platelets. Not only that, there is many clotting factor abnormalities that happens in uremia. That is not fully correctable by any form of renal replacement therapy except transplant. So the only way, even some patients, adequate dialysis helps in controlling uremic bleed. If somebody has a massive GI bleed before, in fact, it is an indication to initiate patients on dialysis. So what I am trying to say is, just by doing heparin free alone, we may not be able to get over this problem.
Okay, Ramya, quick 1 or 2 remarks, and then we go on to Manoj's talk.
I was having the same question in mind, sir, because last week we had a patient who has diabetic kidney disease and recurrent with heme, and he undergoes dialysis on Monday, Wednesday, and Saturday. So we were thinking that heparin plays a role in the repeated bleeds in the eye. So we were wondering when to schedule the vitrectomy for the patient. So we were quite confused. So as you say, sir, heparin is not actually causing the repeated bleeds in the eye. So now it's a little more clearer.
Absolutely.
So, I'm not saying it is not, but what I'm saying is one among the contributing factors. You cannot blame entire thing on the heparin alone.
I understand, sir. I understand.
Ram, I just want to ask you, is hypertensive kidney disease more common or diabetic kidney disease more common?
So if you look at, I have shown you the numbers on chronic kidney disease. If you look at it, predominantly it is diabetes. Even in end stage, look at it is diabetes. The second common cause is hypertension. So if you want to know the numbers in dialysis, around 40-45% is our diabetic population, 20 to 25% is our hypertensive population. Together, they comes around 75 to 80% of all our end-stage kidney disease population.
Now, how do you know it is hypertension which is causing the diabetes? The kidney disease, or the diabetes which is causing the kidney disease?
So if you want to be exactly want to know, it's the only way is to do a biopsy. And without a biopsy, see, the structure of kidney damage is different from diabetes compared to hypertension, because diabetes is predominantly a glomerular disease. There is a in the kidney nephron structure, predominantly glomerulus is one portion, tubular interstitium, blood vessels. What we call as there are four compartments of the kidney. One is glomerulus, other is tubules, other one is interstitium, other one is vasculature. So if in hypertension affects predominantly the vasculature, whereas diabetes affects predominantly the glomerulus. Although to a certain extent it affects vasculature, predominantly the proteinuria comes from the glomerulus. So unless you do a biopsy, you won't be able to identify. But there are indirect ways of looking at it. If somebody has a grossly shrunken kidney, it is very unusual in diabetic kidney disease. Diabetic kidney disease, people will have enlarged or normal kidneys even at end stage. So there are some indirect ways of looking at it, like having associated retinopathy, severe proteinuria, normal sized kidney, long duration of diabetes. These are all ways to look at it, but nothing is foolproof. The gold standard is to only do a biopsy and find out.
Will your management change if it is diabetes, and is it really worth doing a biopsy?
So in some patients, yes. If somebody who is rapidly there is something called natural history for every disease. for every chronic kidney disease. Like we know that the polycystic kidney disease progresses at certain rate. Interstitial nephritis progresses at certain rate. Glomerulonephritis progresses at certain rate. Diabetes is the fastest of all. So I will be happy to treat non-diabetic kidney disease than a diabetic kidney disease. So if I have a biopsy, especially in a diabetic, if I find a non-diabetic kidney disease, it is reassuring that this fellow is going to go slow compared to a diabetic fellow. So is it worth doing biopsy in everyone? Very difficult to answer that question. If you have directly all markers towards diabetic kidney disease, may not be worthwhile in biopsy.
Dr. Ram, there's another question I have, quick question. You know, in some of our early diabetic macular edema, we advise them non-steroidal anti-inflammatory drops, NACID drops. So some of them have been told by their nephrologists, no, you have, you know, chronic kidney disease, so don't use NACID drops. I mean, the systemic absorption of that is minimal. So do you, what would you recommend?
So we only advise to them to avoid systemic drugs, not the local administration of NSAIDs. I think systemic absorption of locally administered drugs are very, very minimal. I don't think there is a huge data to support that to avoid. Then there are people who go to the extreme of not avoid even in NSAID creams outside for some pain somewhere. So I don't think we have come to a stage to have complete NSAID phobia. I think we can continue to use local administration, but definitely we have to avoid a systemic administration.
Okay. So, sir, Professor Shantaram's comments on Manoj's talk, sir.
Manoj, cardiology.
Manoj, yeah, we'll take some questions on that, the panel also.
He has already highlighted that diabetes is the driving force behind the cardiovascular epidemic, and 2/3 of diabetics die of cardiovascular disease.
Yes, sir.
It affects the heart through coronary arteries, through the microangiopathy, producing the cardiomyopathy, as well as the heart failure.
Yeah, Manoj, I just want to ask you one question, Manoj. How different is the pathogenesis of diabetic retinopathy and cardiovascular disease?
I think there's a significant...
Retinopathy and nephropathy and neuropathy go together. That's called the root triad. But
yeah,
because you said macrovascular, microvascular. So how different is we never, whenever we see a retinopathy patient, we always ring up the nephrologist and talk to them. But we never ring up the, talk to the cardiovascular, the cardiologist. The simple reason is that we don't find any relationship between this and that. We thought, okay, is there any relationship between the pathogenesis of the retinopathy and the cardiovascular disease in diabetics?
I would say the only thing which I can conceive is it involves the larger arteries like the conduit medium-sized vessels and the arterioles as compared to the capillaries and smaller arterioles in the microangiopathy. And is predominantly driven by endothelial plaque formation and progressive atherosclerotic cholesterol lipid deposition. So that is where the more of the ischemic events and acute coronary and chronic coronary events and also cerebrovascular events happen. So it predominantly involves the larger arteries, but for that they may not be, there could be associated microvascular disease also, because we also see in diabetic patients with coronary artery disease also having microvascular angina, because sometimes when we do the angiogram, we will see patients may not have a significant epicardial coronary or large coronary or vessel disease. They have minimum plaques here and there, but they will still have intractable angina. And that is probably related to the microvascular and endothelial dysfunction at the arterial or subarterial level. So these are things that I can understand the differences between the two.
Yeah, Sujata and Manoj Khatri and Ramya.
For a minute.
About the cardiovascular.
Not for the retinopathy part, sir, we are not worried about, but if you see the other spectrum of any other vascular disease, especially the recently, I think Dr. Manoj has seen one of our patients who had a branch retinal artery occlusion. So those kind of diseases, I think we are more, worried with the cardiac workup than any other systemic workup. And I will be particularly interested to know, or maybe we can initiate one of the trials where we're looking at the SGLT data, quite impressive. Dr. Vijay's talk and also Dr. Manoj's talk and Dr. Ram's talk, and looking at the progression of retinopathy in future. You know, if SGLT is such a game changer for your systemic disease, I'm 100% sure it will be a game changer for retinopathy per se as well. So this subset of patient, I think we should be closely working on as a team and looking at what's happening to this patient. I think that will be quite interesting to know, because the burden of diabetic retinopathy is increasing year on year globally, and especially with Southeast Asian population. So I think this is one area of interest which came to my mind from today's talk, which will be very much willing and likely to be closely associated and working on this.
Yeah,
I think there's a significant scope to involve in the research, particularly with the rampant use of SGLT2, because in fact, a couple of international speakers who came were also the principal investigators of various trials related to the SGLT2. When they came to Chennai, I did ask that why not involve retinopathy as one of the endpoints in the trials. And they probably missed out on that because, and they said there are some animal models where they found that there could be significant delaying in the progression, particularly the neovascularization. So that was the initial animal model details available with the use of SGLT2. I think there's a significant scope for us to involve and understand the progression of retinopathy in patients.
On similar lines, on the similar lines, because retinologists were the one who said, there is a on the pioglitazone use when it was very rampant few years back. So yeah, diabetic macular edema was worsening, and we were the one who told at least cut down the use temporarily to get rid of the diabetic macular edema. So I think something like this, a landmark thing, can come up in future, which will help the patients at large. Yeah.
Sujata, I would like to ask anything regarding the cardiovascular to Manoj. Unmute.
Fantastic talk, Dr. Manoj. I think
Thank you.
The emphasis has been on lifestyle changes and reducing your BMI, and also the other comorbidities can be reduced. I think once you improve the cardiovascular status, diabetes also needs to be controlled. I think we can avoid the cardiovascular complications. That's what I got from Dr. Manoj's talk, and really fantastic. Thank you, Doctor.
Yeah. I think we do see, despite all these advances and academic forums and continuing medical education for the patients as well as for the practitioners. I happened to see a patient yesterday who was admitted in a diabetic coma in Chettinad Hospital about 3 weeks back, and then he came with a ECG abnormality. See, when he was admitted with coma in Chettinad Hospital, his blood sugar was 1042.
1042?
Yeah. So that is the highest that I could see in my clinical practice.
How are they able to measure this? Is there a meter which can measure the
that was reported actually. That was reported 1042 actually. 1042. His HbA1c was 14 point something, and of course they controlled him, and he came walking because the ECG abnormality, and he had a massive MI which was very silent, and he had a critical coronary artery disease. He was reluctant to subject himself because he said, I don't feel anything, because he has a large ulcer on the sole, and he can walk even on the fire without feeling anything. So he's benumbed all over the body. I think I can put a scalpel on his chest without even a general anesthesia.
Manoj, one more question before we switch. I just wanted to know, you said there is no point in taking any of these blood thinners, ecosprin and
aspirin,
which is quite surprising, because almost all the physicians, as soon as you have hypertension or diabetes, they prescribe aspirin. So what is your...
I think it is, what is important is to control the cardiovascular associated risk factors like hypertension, do away with smoking, and also the statin, particularly after the statin use has significantly enhanced, the atherosclerosis progression has reduced. In fact, the use of aspirin in primary prevention before they've had any event only causes more of GI bleed and other associated issues. So the scope of aspirin has become diminutive now, and it's become less and less and more in secondary prevention after the ischemic events have happened.
Very nice, Manoj. Ramya, your take on this. Manoj.
During the treatment of retinopathy, we most of the times we give anti-VEGF injections. So if there is any recent stroke or any significant cardiovascular accidents, we ask them to take an anti-VEGF injection. And sometimes we ask for a cardiologist fitness whether the patient can undergo an anti-VEGF injection. So can I know which are the parameters you actually consider, sir, before giving a fitness? Or is it safe for us if the patient does not have any recent events, we can prescribe anti-VEGF without a cardiovascular fitness?
I think when I read about some of these Lucentis and similar other injections, I could guess that there are some reports about ischemic events and thrombogenicity in some, and also increase in hypertension levels. So I think we need to look at those parameters, and if they've had any recent thrombotic events in the past 3 months or 12 weeks or so, it would be appropriate to defer until such time, because 3 months is a period that we see they reasonably get stabilized about all risk factor modification and appropriate therapy. And hypertension control is very, very important in these patients, because either bleed or even thrombosis both can be increased by the fibrinoid degeneration in the arterioles with the accelerated hypertension. So both is important to look at.
I think it's a very important message Manoj has told. As ophthalmologists, we should know that before giving an anti-VEGF, make sure the blood sugar is normal, number 1. Number 2 is also your BP is also normal. Because if you have a high BP, then you can have an embolic episode. Am I right, Manoj?
Yeah, certainly, yes.
Yeah, absolutely. Professor Shantaram, sir, any quick comments? And then we'll go on to Supriya's talk on diabetes and eye. I want your comment on that, sir.
So earlier we used to have called what is stiff heart in diabetics. That is microangiopathy and microinfarcts. The cardiomyopathy in diabetes, you will have a small stiff heart, not an enlarged heart. So we should not always think cardiomyopathy, you will have an enlarged heart. Normal size is a smaller heart with a cardiomyopathy. And microangiopathy is well known in microangiopathy of cardiac tissue is well known in diabetes, apart from the kidneys and the eyes. Whereas neuropathy is mainly, it is a metabolic complication, except the mononeuritis, where you can have a vascular component. Polyneuropathies are mainly metabolic. So Professor Sanjeev Mose used called as a triopathy, nephropathy, cardiopathy, cardiomyopathy is a retinopathy.
Yes, sir. So regarding the retinopathy, sir, I want some comments from Manoj and also Sujata and Ramya and Manoj Khatri also, and Ram Prabhakar. What exactly is your take on that? Regarding Supriya's talk.
So for us, it is a lot of learning. That's what I would say, because it's hardly we get time to look at learning from our.
I wanted to ask Professor Shantaram, because he's here. I just want to ask him. So we have a lot of patients who are coming to us and saying that they have a progression of retinopathy, but their diabetes mellitus is not under control at all. In fact, the beginning of the lecture, I wanted to ask you this question. And they are on the maximum dose of insulin or whatever they say. So when do you call these people are insulin resistance? Because every time their blood sugars are around 350, 400, and they have taken all the drugs. I've consulted so many diabetologists, about 10, 15 diabetologists, and all of them, each of them are giving some drug, and I've tried everything. I'm not taking any carbohydrate at all. But despite that, your blood sugars are not coming down. Retinopathy is progressing. HbA1c is 9, 10, 11, like that. So what do you do for these patients? Do you call them insulin resistance? Do you feel these patients require insulin pump or something like that?
What happens in a patient who has got good lifestyle modification, who has been on a maximum dose of oral drugs or a combination of oral drugs and insulin is still not under control. The operating factors for look at whether he has got any uremic insulin resistance, because long-standing diabetes, retinopathy may have uremia, can have uremic insulin resistance, can interfere with the control. The next thing is when you give a large dose of insulin as a single dose, there is a down regulation of insulin receptors, and also the pressure of the insulin molecule interferes with absorption of the insulin. When insulin is given in small frequent doses, earlier pumps are available now. In the earlier days when pumps were not, we used to put a scalp vein, give insulin 5 units every hour in the scalp vein. So with what control you could not get with 40, 50 units, you'll get with 20 units. But when you increase the dose of insulin, sometimes you can have down regulation, insulin receptors that can prevent the thing. And also, you have to control the glucose in the lipids. The lipotoxicity and the glucotoxicity can also induce resistance. And they are not able to control as an outpatient with a combination of insulin orally. Better to admit them and treat them with IV insulin and reduce the glucose levels to prevent the glucotoxicity from operating. So, that rule out the uremic insulin resistance in a patient who's got a proliferative diabetic retinopathy and not responding to the maximum dose of oral drugs and the combination of oral drugs and insulin, especially when there are multiple doses of insulin. And you have to admit them to control and remove the glucotoxicity. Even after removing it, if somebody is not responding, it is worthwhile going on the insulin pump.
Yes, sir. And also, you are mentioning a few minutes back about diabetic memory, sir, in diabetic retinopathy, which means that in the first 5 years or 10 years, if the control has been good, they have less chance of developing retinopathy. Can you exactly elaborate on that particular thing, sir? What exactly it is?
Memory, that the good control produces epigenetic changes in the DNA. So even when you lose that control, the memory of the good control prevents the complication later on. That has been shown the UKPD's follow-up after 10 years. When the patient was the intensive arm as well as the conventional arm, when they were having the same glucose levels after 10 years, they were able to prevent the diabetic retinopathy. This is because epigenetic changes in the DNA. That is for any diabetic complaint, even nephropathy, say first 10 years, 12 years, if we don't develop nephropathy, then the risk of developing nephropathy after that is very, very minimal.
Even nephropathy, it is less.
It is not good.
Okay, sir. Even nephropathy as well as retinopathy, the first 10 years are very important. Right, sir?
Diagnosed at the onset through early screening, and control good for the first 8 to 10 years. And even if the control is not good for 10 years, the risk of complication is less. But if we do not control in the first 7 to 8 years, that we control later, then the benefit is not much.
This is really a fantastic message. I think everybody. So we used to wonder why some patients, despite the fact that they are having control recently, they're very good control, they're having progression of diabetic retinopathy. But probably because 10 years back or 15 years back, they had very poor control in the beginning. So that is the reason why probably they went into diabetic retinopathy or nephropathy for that matter. So any quick comments on this, Manoj, on Supriya's talk, Manoj Khatri, and Sujata and Ramya also? And then we'll come to the end of the session.
Nothing much to add, sir. She has covered everything very excellently.
Excellent talk, Supriya. Excellent. From A to Z, from cornea to retina, she has elaborated.
I want you to highlight one or two important aspects, because Supriya talked about diabetic retinopathy, about what happens in the cornea in diabetics.
Cornea per se, I think only the healing, there can be epithelial issues. They can go in for recurrent corneal erosions. That means the epithelium peels off frequently in these people because the basement membrane is not stable. And that's the reason why after vitrectomy, some of these patients land up with repeated corneal erosions. That is one big bugbear for them. And because of that, they can go in for secondary infection also. And because of poor control of diabetes, the healing factor and the chances of fungal infection also increases a lot in patients with diabetes. That is one thing from the cornea aspect. From the refractive aspect, when we look at doing LASIK on these patients, as long as their glycemic control is good, we can still go ahead with doing LASIK. And there is healing is absolutely not a problem with them as long as the glycemic control is good. So these are 2 points I would say. Then the third important point is like in patients with keratoconus, if they are diabetic, we don't even have to cross-linking because the corneal cross-linking happens more. Probably that's the only good thing about diabetes is that the cross-linking of the collagen is faster in diabetics. So the need to intervene is you can take your time about these patients. These are 3 points from the cornea aspect.
So that is one thing about the cornea, and also cataracts, the increased incidence of cataracts in diabetics, the posterior subcapsular cataract, very, very typical of diabetics. That's a very, very straightforward thing. Ramya, you have anything to add for diabetic retinopathy?
No, sir. No, sir. Just enjoyed ma'am's talk a lot. Nothing to add.
Absolutely. I think it's very important that we have a complete multidisciplinary approach to manage all these problems, the problems because of diabetes. So final words from Professor Shantaram sir on this webinar.
Excellent webinar session, useful to the practicing physicians and to the general public on how to deal with the management of diabetes and prevent these catastrophic complications.
Thank you very much. Wish you all a very happy, safe Diwali, and hopefully we'll all be able to collectively work together and take care of the patients who got this diabetes and end-stage complications as well. Thank you very much. I would like to thank Professor Shantaram for being here. It's a great honor and privilege to have you, sir. And of course, the fantastic speakers, Vijay, Ram Prabhakar, Manoj, and I request Dr. Ravi Shankar, my co-moderator, to propose a vote of thanks.
Thank you. We've come to the end of this session, and I know very well that I stand between you and your dinner. So I quickly complete heartfelt thanks from Team Rajan Eye Care, from Dr. Mohan Rajan, Dr. Shweta Mohan, to Professor Shantaram for his excellent involvement in this session and teaching us everything and telling the public what they should do and what they should not do. Thank you, Dr. Vijay Viswanathan, for making it much crisply interesting and telling us regarding the scenario of diabetes in India. Thank you, Dr. Manoj, for telling us the relation of cardiology with diabetes so excellently, telling that heart failure is much more primary than a myocardial infarction. Thank you, Dr. Ram Prabhakar, senior nephrologist, for telling us that gone are the days where you think of other parameters. You need to think of eGFR and you have to think of the albuminuria. Thank you, all four of you, for making this session wonderful. I need to thank Dr. Supriya Dabir Gautam for telling us on diabetic retinopathy, the prevention and management. And I need to thank Dr. Shweta Mohan panelists, Dr. Manoj Khatri and Dr. Ramya being the panelists of this wonderful session. And thank the audience and the general public who have attended. There's a big numbers, I was told, from the YouTube links and the Facebook links. There are many viewers who have joined us today. Thank you very much, dear audience. I think at the end of the day, it's very useful to you. I need to thank the medical support team who have made this happen, the Sun Pharma Milmed Group who've been supporting us. Thank you, Mr. Raju, Mr. Alex, and Mr. Israr. Thanks a lot. Thank you, everyone, for joining us, and hope to meet you soon and get the best benefit to our patients at the end of the day. Happy Diwali and a lovely good night to you.
The whole webinar will be available on the YouTube very soon. We'll be sending you the links, and hopefully it will benefit a huge number of people, both medical as well as non-medical people, to take care of the diabetes. Thank you very much, sir.
Thank you. Thank you.
Thank you all. Very safe.
Thank you.
Thank you.
Thank you. Thank you. Have a happy Diwali, everyone.
Thank you, sir.
My father-in-law, Dr. Krishna Gopal, wishes you all and blesses you all.